conference, and I would like to remind all parties the call is now being recorded. If you have any objections, please disconnect at this time. And I would now like to turn the call over to Dr. Burkey. Thank you. You may begin.
Thank you. Good morning, everyone, and welcome to the first meeting of the Advisory Committee on Heritable Disorders in Newborns and Children for 2019. So welcome. We will begin this meeting with a roll call of the members and the organizational representatives. So first, Agency for Healthcare Research and Quality, Kamala Mystery. May Baker.
Here.
Susan Berry.
I'm sorry. Here. Listen for a second. Hang on one second.
Here. Jeff Brasco is seeing patients. He'll join us in a little while. Carla Cuthbert. Kelly Kelm.
Here.
Michael Warren.
Carla Cuthbert is here. Dr. Boccini.
Thank you, Carla. Cindy Powell. Melissa Parisi.
I'm here.
Anne-Marie Saarinen.
I'm here from Mongolia.
Scott Schoen.
Here.
Beth Torini.
Here.
And Catherine Riley.
Here.
Now for our organizational representatives, American Academy of Family Physicians, Robert Ostrander will join us later. American Academy of Pediatrics, Deborah Friedenberg.
I'm here.
American College of Medical Genetics, Michael Watson.
Here.
The Association of Maternal Child Health Programs, Jed Miller.
Here.
Association of Public Health Laboratories, Susan Tanksley.
I'm here.
Association of State and Territorial Health Officials, Chris Kuss. Genetic Alliance, Natasha Bonham.
I'm here.
Marcia Dimes, Rebecca Abbott.
I'm here.
National Society of Genetic Counselors, Kate Walsh-Bockley.
I'm here.
And Society of Inherited Metabolic Disorders, Sean McCandless. All right, well, thank you. Next on the agenda is the November minutes.
Oh, let me do it. Yep.
Okay. So committee members received the draft of the minutes of the November meeting to review prior to this meeting. We incorporated revisions submitted by committee members and distributed a final draft of the minutes to the committee prior to the meeting. Are there any further additions or corrections to the minutes? Hearing none, we will need a vote for acceptance of the minutes. So once again, Kamala Mystery. May Baker.
Who?
Susan Berry.
Please.
Carla Cuthbert. Carla, are you on mute?
She's disconnected.
Oh, she was disconnected? Okay. All right, get back. Kelly Kelm.
Approve?
I'm sorry, was that Kelly? Okay, thank you. Kamala Mystery. Melissa Parisi.
Approved?
Cindy Powell. Anne-Marie Saarinen. Michael Warren. Approved. Scott Schoen.
Approved.
Beth Torini.
Approved.
All right, thank you. The minutes are approved.
Mm-hmm.
Oh, okay. All right. Next on the agenda is the new work group members. As you know, we asked for submissions for individuals who are interested in serving on work groups. And so first I want to thank everyone who submitted applications to serve on the work groups. We received many excellent applications and have selected 12 new work group members. And on the next slides, you'll see the individuals who were selected. We encourage those who are not selected this year to please apply again next year at the next opportunity. So the following individuals were selected to serve on our work groups. For the Education and Training Work Group, Sylvia Mann, Maoi Kwamen, Samantha Vergano. So we welcome the three of you to the Education and Training Work Group. Next is the Follow-Up and Treatment Work Group. Tracy Bishop. Tracy Bishop, Luca Bernelli, Lawrence Merritt, and Elna Saar were named to the Follow-Up and Treatment Work Group, and Marcy Sontag. Okay, now we got the slides lined up. Okay, there we go.
There we are.
Okay, and then for Laboratory and Standards Work Group, we have Natalie Lepage, Miriam Schechter, Stan Barbarish, and George Desikas. So I want to welcome all of you to the committee, to the work groups, and we look forward to your active participation in the activities of each of those important standing work groups of our committee. Next is new organization representatives. I want to thank everyone who applied to their organization for a position as an organization with a representative. We are finalizing those selections and plan to bring on approved new organizations and the representatives by the April meeting. I have one more change to announce. My term on the advisory committee is coming to an end. The April meeting will be my last meeting serving as your chair. After 8 years in this position, it's time now for a transition. I'll have much more to say about this at our April meeting about my term and how much it has meant to me to have been given this incredible opportunity to lead this committee and to work with so many extraordinary, dedicated individuals. And so we'll talk more about that in April. So I'm pleased to announce that following the April meeting, the new chair of this advisory committee will be Dr. Cindy Powell. Dr. Powell has served with distinction on this committee since 2017 and is an excellent choice to lead the work of this committee going forward. Dr. Powell will also have more to share with us at the April meeting. Next slide. The next slide shows our future meeting dates. The next committee meeting will be held April 23rd and 24th. It's in person here in Rockville. And then you can see the meeting dates for the rest of 2019, August and November. And the meeting dates through 2023 can be found on the committee's website, which is listed on this slide. So the next slide shows today's meeting topics. Today we will hear an updates from the ad hoc work group on risk assessment. And interpretation of newborn screening results. And we'll have an initial presentation on the expert advisory panel meeting, which was held in February to review the committee's nomination, evidence review, and decision-making process. Next slide. We'll also have a initial discussion on the project assessing the impact of adding conditions, the recently added conditions to the RUSP. We will also have a presentation, a panel discussion on potential resources for facilitating rare disease research and data collection. Next slide. Now I'm going to turn the presentation over to Catherine Riley, who will go over the DFO slides. Catherine.
Thank you, Dr. Burkey, and good morning to everyone who's joining us across the country. We know for those on the West Coast, it's an early morning for you, so welcome to everyone. The Advisory Committee's legislative authority is found in the Newborn Screening Saves Lives Reauthorization Act of 2014. This legislation established the committee and provides the duties and scope of work for the committee. However, all committee activities are governed by the Federal Advisory Committee Act, or FACA, which sets the standards for the establishment, utilization, and management of all federal advisory committees. As a committee member on a federal advisory committee, you are subject to the rules and regulations for special government employees. Next slide. So I have some standard reminders to the committee that I want to go over. I wanted to remind the committee members that as a committee, you are advisory to the Secretary of Health and Human Services, not Congress. For anyone associated with the committee or due to your membership on the committee, if you receive inquiries about the committee, please let Dr. Burkey and I know prior to committing to an interview. I also must remind committee members that you must recuse yourself from participation in all particular matters likely to affect the financial interests of any organization with which you serve as an officer, director, trustee, or general partner, unless you are also an employee of the organization or unless you have received a waiver from HHS authorizing you to participate. When a vote is scheduled or an activity is proposed and you have a question about a potential conflict of interest, please notify me immediately. So according to FACA, all committee meetings are open to the public. If the public wish to participate in the discussion, the procedures for doing so are published in the Federal Register and the announcement at the end during the opening of the meeting. For this meeting, there were two requests to make oral comments received, and we did not receive any written statements ahead of time. Good. Okay. Also, public participants should be advised that committee members, if we do receive written comments, would be given copies of all written comments ahead of time. Any further public participation will be solely at the discretion of the chair or myself as the DFO. Before we proceed, I want to see if we have any questions from committee members. Okay, and then I wanted to, as a webinar, just do a quick reminder just about the logistics of the webinar. For the members of the public, the audio will be coming through your computer speaker, so please make sure, obviously, you have your speakers turned on. There's also an option for calling in if you get disconnected so that you can hear the proceedings. For the committee members and org reps, your sound will be coming through your phone line, so please make sure your computer speakers are turned off. This will help lessen the possible feedback. Also, please speak clearly and please remember to state your name first to ensure proper recording for the committee transcripts and minutes. Since we're not in person, I won't have my fun sign that I put up for people, but if you could remember to please state your name first, that would be very helpful. For the committee members and org reps, if you have any issues with the phone line, you can press *0 and you will get the operator for assistance. In order to better facilitate the discussion during the discussion points of the agenda, please use the raise hand feature in Adobe Connect when wanting to make comments or ask questions. This is, if you can simply click on the person icon at the top of your screen, it's kind of in the middle section, and it'll choose raise hand. This will allow us to put you in the queue. I'll unselect your name once you're in the queue for making a comment, and Dr. Burkey will announce who's going to make the next comment or question. And if you have any questions, please let us know at this time. Okay, then I'm going to turn it back over to Dr. Burkey. Thank you.
Thank you, Catherine. So we're ready for our first presentation for today. and it's on the ad hoc work group updates, risk assessment, and interpretation of newborn screening results. And our presenter is Dr. May Baker. May is a committee member and serves as chair of this ad hoc work group, which was formed at our last committee meeting to focus on two major charges. This work group brings together expertise from the laboratory work group, education and training work group, and organizational representatives. We asked Dr. Baker to provide an update on the work group's initial ideas for addressing the charges of the committee. And so those charges, just for a quick review, were to address opportunities and challenges related to interpretation of newborn screening results, and this would include communicating the strengths and limitations of newborn screening results and educating different audiences, providers, parents, and the public about what newborn screening results provide for their patients or their families. The second charge is to consider options for the committee that could help states with risk assessment policies that would help them utilize more efficiently the resource document that was put together by APHL. So May, I'm going to turn the presentation over to you. Thank you.
Thank you, Dr. Burkey. Good morning, everyone. Next slide, please. So here is our work group members. As Dr. Burkey stated, the people on this group have a variety of expertise. And this group, we met over the phone on March 15. So I am going to report our discussion to the committee members. Next one, please. As Dr. Burkey stated, we have two charges. And the first charge, we emphasize newborn screening results interpretation. In that, the charge, we would emphasize risk assessment, and we also will discuss some terminology utilized in the newborn screening, and in the hope to clear some confusion. And also, we will try to interpret all test categories. So I think historically we emphasize screening positive, screening abnormal, but we feel it's the time we also want to address when screening negative, when screening normal, what that means. Also, we want to spend some time to really emphasize how we communicate the message, and this work will be based on the education subcommittee already done so much, and we want to be based on that and see if we have any other avenue we can enhance. For the charge 2, and emphasize is the recommendation regarding screening cutoff establishment and monitoring. As Dr. Burkey said, APHL QA/QC committee has created very comprehensive documents, and we want the work group review them and look at opportunity to make some recommendation and to the field. So we'll emphasize thinking the cutoff, we need to think both sensitivity and specificity. And we also want to promote the idea in terms of ongoing evaluation and make adjustment when this is necessary. Next slide, please. So how we go about addressing work group the charges. So from now on, I will talk the two charges separately so will not cause any confusion. For the charge 1, the first, we want generate a report to the committee. Oh, sorry, my screening went away. I'm trying to, give me 1 second. And also, we hope to put impact. When we have the report, we hope to, based on the report, generate a peer-reviewed journal so we can more establish and also subject to the peer review and hope we can even reach more wide audience. And third, and based on the report, based on the publication, we want to generate called a slide deck so we can become more convenient for the clinician to use and even other tools. For the charge 2, and our goal is to drop the possible recommendations and to the committee for committee to make final decision how we do the recommendation. Next slide, please. So now I am going to present some general principle in terms of the work plan. When I say principle, because we still need to work on the details. And the work plan, we have 3 parts. First is introduction. In the introduction, we want to address the rationale and the target audience. So as Dr. Burkey states, and we have, well, the first target audience is family family doctor and pediatrician, but we know they're the people to communicate the result to the family. So in the end, we want to be sure the message can be well understood and interpreted by the physician and the family receive the results. And in terms of rationale, and think this group of members is very familiar with in terms of newborn screening practice have been long time, and even certain things we do doesn't necessarily be well, the perception, the public maybe not always exactly what we intend to do. So I think it's time we're trying to find knowledge gap and unmet expectation. So the key elements here are, screening versus diagnosis. And also we will attempt to do some terminology harmonization, and so people will understand better. Next part is, beside the concept, also we want to really get more detailed in terms screening test or versus diagnosis test, because the purpose, the population is very different. So to achieve this, we will go to the literature and find a reference. And actually, we did some preliminary work. It's just not very much over there. And that also enhanced the importance why we needed to do that. And certain things have been done by other groups. An example is called MOC4 from the Midwest Genetic Network. I think I'm very pleased is we have 2 members on this group. Actually, they were very engaged with the activities, and actually I believe they're leaders. So we'll be bringing this perspective to us. And also, I recently learned HRSA is developed some kind of documents. So we hope they will be in the public domain, and we can cite them, and we can talk about their work. I do believe APHL QA/QC committee is doing some similar work. We hope we can keep communicating with everybody. Another thing that we want to address is, come to newborn screening, our emphasis a population. The things, the decision we made is based on the population. We need to be mindful, and the public needs to know sometimes individuals, the special circumstance could somewhat deviate from the general population, and we need to understand that. Next one, please. The work plan part 2 is to describe the current practice, with the emphasis is risk assessment. So we can describe how practice in the newborn screening setting. And I think the channel for us to communicate with public, with primary care physician, is through newborn screening report. So the group will describe the current, in a different scenario, how we report the newborn screening. So here is a several example. And the group member believe not just a term, it's what the term entail, what is the action need to be taken, I think is more important. So for the first one, it's really need further action taking. This action actually is ask for confirmatory test. People use a different term, screening positive, abnormal screening of a range. And another category is the further action needed, but their recommendation is repeat the newborn screening. So people use the term borderline, possible screening positive, possible abnormal. And third category is no further action unless clinically indicated. So this one, we will be very carefully how we wording them and not cause anxiety at the same time. People need to understand that when we say no risk, doesn't mean zero risk, just like everything in the medical practice field. Another category we would address is we now put in the unsatisfactory. Is in a different situation, you really cannot have a decision because of the interference and the situation. So we will discuss more. And a very interesting worker group actually talk about when you have two screening protocols in some states, and when you have the first one, you may not make decision until second one come in. So we kind of talk about how the terminology used. And for now, we put it like pending. Next one, please. The work plan part 3 is discussion and recommendation. So the goal is trying to make newborn screening assessment more apparent. Is we will utilize the language. For example, you can say, well, when this is a level potentially certain disease, then we maybe just directly use risk. So I think this is a more real-time reminder of a physician when I read the report. Also give them a tool. So then they have this kind of wording that may translate to the family. So that's the kind of strategy we will discuss more. And as I stated earlier, so we will put some language, recommend some language for normal newborn screening results. Again, we'll discuss about terminology, and we'll attempt to harmonize that. But this is not a small test. We recognize that so we can see how far we go on that. And the third one is the strategy for communication. As we said before, we're going to hope we can build what's already been done and see if we can have even more tools to provide to the physician when they're communicating newborn screening to the family. Next one, please. So here is our timeline. As I stated before, so far we have done quite a bit, is more emphasized charge 1. So today we will have discussion, and we're looking forward to the feedback from committee members. And we hope at the next meeting in April, and we'll have outlines for the report. Also started to discussing some dissemination plan and seeking feedback from the committee. And by August, we hope we have a draft report and also have a more refined dissemination plan. When we talk this, something in our mind already, such as profession conference, so we can do some presentation, and also through our organization representatives, we may help to get our report or white paper be in their website, so kind of have accessible to their members. And that's the kind of thing we are talking about. And then we also want to start to draft a recommendation for the charge 2. So by November, you can tell we will, that's our plan, to have a final report and start to do some dissemination activities. And we hope by that time we're ready to prepare the manuscript. And for the charge 2, we want to have a draft recommendation and seeking feedback from the committee. And the next year, February, and we hope we can finalize the recommendation, also have a further reporting on the dissemination activities. And by that time, we can submit the manuscript. So I will end over here, and thank you, everybody.
Hey, thank you for a very nice update, and it's clear your work group has gotten a really good start. So let's, we have about 10 minutes for questions and comments for May. So operator, if you'll please open the lines for committee members and organizational representatives. We're going to give committee members the opportunity to raise questions or give comments first, followed by organizational representatives. As a reminder, please use the raise hand feature in Adobe Connect when wanting to make comments or asking questions. And when speaking, please state your name each time to ensure proper recording of the conference. So let's open this for questions and comments.
Dr. Burkey, this is Catherine. I'm not seeing any hands raised on the webinar at this time. Over the phone, if any of the committee member or org reps have a question or comment, could you go ahead since we can't see a hand raised?
Okay, your lines are open.
We have Chris Cutts and Sue Berry.
Okay, first Sue Berry, and then Chris Cutts. Sue?
Can you hear me?
Yes, we can hear you now.
Okay, thank you. I just had muted my phone because you know where you are. So I'm happy because May mentioned our MOC4 project. If anybody has questions about that, I'd be happy to respond to them. But I'm excited that we're moving forward with this. It's more a comment than a question. Thanks.
Thank you. Chris Kuss?
Yeah, my comment was that I joined late and I'm here. Thanks.
Okay, thank you.
So, this is Debbie Friedenberg, and I just have a question. A lot of the activities that are part of this work group are also being addressed by other organizations that have an interest in newborn screening, and is there any plan for harmonization or any plan to include those activities?
May, you want to take that?
Yeah, I'm trying to understand the question a little bit better. If I understand it correctly, Debbie, you was asking is because this kind of the activities is also of interest to other organizations. So how we collaboration with them, or could you repeat your question?
Right. Well, that's pretty much it. You know.
Oh, okay. Yeah, and at this stage, as a member, you're on the group, we haven't get that far yet because we will discuss the dissemination plan. And now it's, to me, in my head right now, is kind of one-way street because when I said that, it means we have this and we want them help us disseminate to their members. But I think you bring a very good point. Maybe we wanted them feedback too. So let's talk a little bit more.
Okay, great.
Dr. Burkey, I'm not seeing any other hands raised via the webinar.
Okay. we're going to give one last chance for additional questions or comments. All right, seeing none, May, thank you, and thank the members of your work group. We look forward to the timeline that you have put together and bringing the deliverables to the committee for final decision. So thank you very much for all that you're doing on this topic.
Thank you.
So next item on the agenda is public comments. We have 2 requests for public comments that came in before the deadline. The deadline for signing up for public comments was March 18th. So we have 2 individuals who are going to make comments. The first public comment will be from Annie Kennedy, Senior Vice President for Parent Project Muscular Dystrophy. Operator, would you open Ms. Kennedy's line?
Good morning.
Ms. Kennedy, can you hear us?
Good morning. Can you hear me?
Yes, go right ahead.
Right,
Thank you.
Good morning. Good morning. On behalf of Parent Project Muscular Dystrophy, I'd like to say thank you to the committee for providing me with the opportunity to address you this morning. Over the last 4 years, PPMD has been leading a national effort to build a newborn screening infrastructure for Duchenne in the U.S., aimed at developing the evidence to support Duchenne newborn screening. Building on the work led by Dr. Jerry Mendel in Ohio State in the newborn screening pilot, which concluded in 2012, PPMD endeavored to learn from the best practices of that pilot and refine the systems further such that they could be replicated in a state with a high birth rate and eventually nationwide. In Dr. Mendel's study, nearly 60,000 babies were screened throughout the state, and 6 children with Duchenne were positively identified, establishing evidence for a 2-tier screen at birth for Duchenne within the U.S. newborn screening system. Our Duchenne effort has convened experts and established the partnerships required to research, pilot, and implement nationwide newborn screening for Duchenne. PPMD's Duchenne newborn screening efforts have included the expertise and input of experts and leaders within NIH, HRSA, FDA, CDC, the American College of Medical Genetics and Genomics, the broader newborn screening community, and the Duchenne community. Our efforts have also included an extensive collaboration with the world's leading scientific and technology developers to identify and refine the screening tests used in Duchenne newborn screening. Based on the experience of the newborn screening programs throughout the world, our efforts have included a study to determine which approach to screening has appropriate analytical and clinical validity and utility for use by public health laboratories. These efforts were conducted in collaboration with the California Department of Health, PerkinElmer, UC Davis, UCLA, Stanford, and UC San Francisco. We are delighted that the yield from these efforts will now be applied to a pilot in a high birth rate state. We've also collaborated with the CDC and the American Academy of Pediatrics to develop diagnostic tools and resources for primary care providers and families. As such, today, I am very proud to share that we have initiated a newborn screening pilot in New York State. The Duchenne newborn screening pilot program is designed to set up, validate, and conduct a consented pilot screen for infants born at select hospitals in New York State, which will utilize tools, resources, and expertise at PPMD and the Newborn Screening Translational Research Network under the leadership of Dr. Mike Watson, Dr. Amy Brower, and Dr. Michelle Prieur, and the New York State Department of Health under the leadership of Dr. Michelle Kajana and Dr. Norma Tavicoli. Our pilot is being funded through a unique model in which PPMD has convened a pre-competitive consortium of biopharmaceutical industry partners with a commitment to early diagnosis and intervention in Duchenne. Consortium members include Sarepta Therapeutics, PTC Therapeutics, PerkinElmer, Solid Biosciences, Wave Life Sciences, and Pfizer. In addition, the pilot is being guided by a steering committee comprised of representatives from federal agencies, provider groups, and representatives from key Duchenne stakeholder communities. To prepare for this moment, PPMD has been working for nearly 2 decades on efforts aimed at readying the landscape for newborn screening efforts in Duchenne. These efforts have included leadership on the Newborn Screening Saves Lives Act, annual Duchenne-specific language within appropriations and report language to ensure that our federal partners are focused on Duchenne efforts, and leading the National Newborn Screening Initiative, which has included the development of published care standards for newborns, publications and ethical considerations for Duchenne newborn screening, and the publication of a roadmap to newborn screening for Duchenne. Today, we're exceptionally grateful to the families, experts, and partners who've helped us to get this far and who've agreed to lean in even further as we move the resources we've developed into this New York State pilot. With 2 recently approved therapies and a research pipeline filled with potential therapeutic interventions, newborn screening will provide optimal opportunities for care and treatment in Duchenne. The initiation of our Duchenne newborn screening pilot in New York State is an exciting and critical next step in improving outcomes for children with Duchenne. Thank you.
Thank you for your presentation and all the work that you have done to bring this to this point, and we look forward to the additional data that will come from your new project. So thank you.
Thank you.
Next, second public comment will be from Brittany Hernandez, who is Director of Advocacy for the Muscular Dystrophy Association. Operator, would you open Ms. Hernandez's line, please?
Good morning, Dr. Burkey. Can you hear me?
Yes, I can. Please go right ahead.
Thank you very much. I'm obviously very happy to follow up on Annie's public comment. Thanks for the opportunity to provide comments today. My name is Brittany Hernandez. I serve as the Director of Advocacy for the Muscular Dystrophy Association. As an umbrella organization representing more than 40 different neuromuscular disorders, including 2 diseases that are currently on the RUSP, SMA and Pompe, MDA is committed to promoting early screening and diagnosis and is eagerly engaged in helping promote additional neuromuscular disorders to be added to the RUSP, including Duchenne. We've been proud to work collaboratively with the clinician, research, and advocacy community on screening efforts around Pompe and SMA, and we're pleased to see their addition to the RUSP in recent years. We hope that the community will continue this collaborative approach as we collectively endeavor to add Duchenne to the RUSP as well. MDA supports a robust network of more than 150 care centers nationwide that provide clinical care and access to support and services to families living with neuromuscular disease, including Duchenne. It's this care center network that will play an important role in the Duchenne newborn screening continuum, as it is able and ready to provide the follow-up care and long-term support for the babies and families identified through the newborn screening process. The Care Center Network, which is led by some of the most respected thought leaders in neuromuscular disease, also serves as sites for many of the clinical trials where potential therapies are investigated for Duchenne and other disorders. MDA also has the unique ability to gather comprehensive longitudinal clinical insights around the newborn screening population through the Neuromuscular Observational Research Hub called MOVER. The MOVER Data Hub gathers information on multiple disorders, including Duchenne, in order to optimize clinical care and drug development with specific emphasis on benchmarking quality of care, safety and effectiveness of new treatments, natural history of disease, and correlation between genotype and phenotype. Through these various efforts, MDA supports thousands of individuals living with Duchenne every year. I encourage the committee to consider the strong follow-up and long-term care infrastructure that's in place to support the community when you consider a future RUSP nomination of Duchenne. As MDA and other stakeholders, including PPMD, have shared with the committee, time is of the essence in implementing newborn screening for neuromuscular disease where early identification and treatment are really important. Together, our collective community of advocacy organizations, clinicians, researchers, and newborn screening experts are working to ensure that these disorders are included in the newborn screening public health program. We look forward to facilitating the addition of more neuromuscular diseases, including Duchenne, to the RUSP as they are ready to meet the rigorous evidence review standards set out by this body. Thank you.
Thank you, Ms. Hernandez. We're really thankful for the work that you've done, your advocacy, and again, we look forward to additional information as it becomes available and we move forward with this project. Thank you. Next on the agenda is a discussion on the evidence review process and condition nomination project that we started. As I mentioned in November, We are conducting a formal review of the entire process from condition nomination to evidence review and the use of our decision matrix. We're considering the development of a process also to reassess conditions which are on the RUSP, as well as a process and criteria for possible removal of conditions from the RUSP. Our aim is to determine whether revisions are needed or need to be made to reflect the most up-to-date approaches for using evidence to successfully develop public health policies, in particular for rare conditions. We formed a steering committee of committee members and experts from the field to provide us guidance for this process. We began with a 2-day expert advisory panel meeting, which was held on February 5th and 6th. So Dr. Alex Kemper, who leads the evidence-based reviews, is helping to lead this effort. He co-chaired the expert advisory panel meeting, and today he will present a summary of the meeting for us. I ask that committee members be thinking about these processes between now and April. And at the April meeting, a draft work plan will be presented for consideration by the committee. So I would like to turn this over to Dr. Kemper, who will provide us with this overarching summary. So Alex, are you online?
I am, and thank you for that introduction. I hope that you can hear me.
We can, so go right ahead.
Fantastic. So it was really an honor to be able to have this meeting last month. And as we're going to talk about, there were a lot of great suggestions about how to continually strengthen the evidence review process and make sure that it fits into the broader activities of the advisory committee. So my goal in this presentation is to really provide a 30,000-foot overview of the kinds of issues that were brought up in this meeting. And then in the April meeting and the subsequent couple of in-person meetings, there's going to be an opportunity for us to really dig into the recommendations and to revise and continually strengthen the process that we use to ultimately wind up with a recommendation for the Secretary around conditions considered for newborn screening. So it was really, one of the key messages I want to deliver is that it was a great meeting with lots of fabulous suggestions. Next slide, Elena. Oh, actually, now I have a little error. I guess I can.
I was going to say, Dr. Kemper, we did turn the slides over to you. If you are happy to advance, or you can advance as well.
I just realized that, so I can take over from here. So
okay, great. Thank you.
The goals of this project, as I've listed here, was to gather information to learn how to improve the process related to each step that ultimately leads to recommendations. So the nomination process, the evidence review process, the decision-making process, and the new aspect that was added in, as Dr. Burkey mentioned, was reviewing those conditions that are currently on the RUSP. So I just want to give everyone a sense of the timeline for this project that will ultimately lead to a final report in March of 2020. The real take-home message from this slide is that there's going to be lots of opportunity for us at the in-person meetings to dig into things. Again, I would be remiss if I didn't thank the expert advisory panel that helped put this together and that ultimately participated in the meeting. And I'm going to go over who that panel's experts included. It did include representatives from HRSA as well as other federal agencies within HHS, a specific advisory committee, our evidence review group, state screening programs, and then a wide variety of other individuals that are involved with the broad range of newborn screening, from the laboratory side of things to diagnosis and treatment, and also included experts in developing evidence-based recommendations. And with that, by way of background, here's a list of the meeting participants, and I'm just going to leave this up here for a second so you can look at it. And I have to say it was a really, really engaging meeting, and included experts in newborn screening not only in the United States but from our neighbor to the north in Canada. So there were lots of lessons that we were able to get from the whole thing. This slide presents topics that we discussed at the meeting, beginning with an introduction to the committee process. We had a rich conversation around GRADE, which stands for the Grading of Recommendations, Assessment, Development, and Evaluation. Dr. Holger Schienemann, who leads GRADE currently, was able to make a presentation not only about how GRADE works, but how it could apply to rare diseases, which, as you all know, is a challenging issue. We talked about how to assess published and unpublished evidence, strategies related to the public health system impact assessment, determining, it should actually say their values, not just value from different perspectives. And again, I'm going to dig into that in a second. We discussed the decision matrix, how to reconsider conditions that are already on the RUSP, and ultimately areas that need further research and development. I'm now just going to talk about some of the key suggestions that came from this meeting, and I'll talk about how I plan to bring these up at subsequent meetings. So in terms of the nomination process, there were recommendations around how to strengthen the nomination process before the evidence process begins. As I think most people know, there's this 9-month window to complete the process for the advisory committee. And there's a discussion around how to make it so that the nomination process could help better inform the work of the evidence review, but also at the same time making sure that things were transparent and that the nomination process itself didn't overly color what might happen with the evidence review process. There was a discussion around making sure that the nomination process clarified the primary and secondary targets of screening as well as the incidental findings, again, to make that more clear by the time the evidence review process began. And there was also discussion about the value of doing a scoping review, so not a systematic evidence review, but an assessment of what literature is out there before beginning the full evidence review process. Of course, that could be helpful in terms of figuring out what evidence is available and where their gaps might be, but work would need to be done in the future to figure out how that process would work. Moving on to the evidence review, and it just suddenly occurred to me with March Madness going on that it'll be kind of fun to talk about net benefit here. But in terms of the evidence review, again, there was discussion about making sure that critical outcomes are identified as soon as the process begins. Based on the grade, there was a recommendation that we even go so far as to predefine a list of core outcomes that we would investigate for all conditions, as well as additional ones that might be added in as appropriate for that particular condition. There was a discussion about also the importance of considering outcomes from a wide range of different perspectives. And again, I'm going to dig into that again in a little bit. One of the challenges that we faced in the past is around gathering unpublished data in the fast-moving field that we're oftentimes in the position of exploring. there's a lot of unpublished information out there, but it's challenging to both gather it as well as to assess the quality of the evidence or the potential risk of bias. And so building off of a process that GRADE does, they have a formal written document that can be passed out or made available to individuals in the field who can then submit where unpublished evidence might be and the strengths and weaknesses of it. That is something I think that it's going to be really important for us to adopt moving forward, and this is one of the central areas that I'd like to discuss in the April meeting. There was broad agreement, too, around looking at issues of long-term follow-up during the evidence review process because of the recognized challenges of long-term follow-up. So that would include describing long-term follow-up plans during the review process and trying to assess the availability of long-term follow-up. Again, these are methods that will have to be developed in the future for the review process. There was strong support about the need to assess values from different perspectives. And in addition to the usual clinical perspectives that we've been able to gather, looking at families' perspectives on various health outcomes and the potential benefits and harms of screening, as well as the public perspectives around the potential benefits and harms of newborn screening. Assessing values in a standardized way to be able to present an evidence review is challenging, and this is something that's going to require a lot of work for us to really be able to put into the process. And in our in-person meeting in April, this is something that I think that we really need to, actually, I apologize. We're not going to dig into the values part in the April meeting because I want to allow our team to be able to do more methods work, and so it'll be the subsequent one. So not the April meeting, not next month, because I don't think that we'll have enough information for people to inform a specific plan, but it'll be the meeting after the April one. So I'm sorry, I misspoke there at the beginning. The decision matrix will be the next big topic that we'll need to consider again. At the meeting, there was a lot of interest in figuring out how values and preferences could be explicitly incorporated into the decision matrix. And there was also strong support for considering resource implications for the states. There was also questions that were raised about whether moving into the future it still makes sense to consider a condition-by-condition approach versus panels. So, for example, you can one participant brought up the issue: what if there's a panel for intellectual disability that could identify a wide range of conditions? Would it make sense to consider each of those conditions one by one versus a panel? And then there was a discussion about whether or not it would be possible to have some sort of provisional or conditional recommendation for the RUS. Again, that's a future issue. Finally, and as Dr. Burkey mentioned, there was interest in updating or reevaluating those conditions that had been added to the RUS previously. So future issues to tackle would include whether there should be a post-RUS surveillance system to be able to assess what the impact was for adding a condition, including addressing things like epidemiology, net benefit, costs, and long-term follow-up effectiveness. Excuse me. There was also support for routinely reassessing conditions on the RUS instead of waiting for conditions on the RUS to be nominated for reevaluation. Again, all these things are open for further discussion, obviously. So in terms of next steps, we need to refine the suggestions and related methods in partnership with members of the advisory committee. And ultimately, our goal is to use all this to develop a formalized manual of procedures. So, so with that, I'll turn it back to Dr. Bocchini and see if there are any questions about this meeting or where things are going.
Alex, thank you for a very nice summary of the meeting and the steps that you plan for going forward. So let's open this up for questions and answers and committee discussion. Again, operator, would you please open the lines of the committee members and organizational representatives? Committee members will discuss first, and again, organizational representatives will follow. As a reminder, again, please use the raise hand feature in Adobe Connect when wanting to make comments or asking questions. And when speaking, state your name so that we can ensure proper recording. So let's open it. So we have first Scott Schoen, followed by Sue Berry.
Thank you, Dr. Bocchini.
You're welcome.
Can you hear me?
Yes, go right ahead.
Great. Thanks, Alex, for the great summary. I have a bunch of questions, but I'll take them one at a time, a step back, and then digest and come back to raise my hand again. But I guess the first question I would throw out there is on one of your slides about the nomination process, you had said to ask the nominators to identify critical outcomes. And I wonder if there's any discussion around even having the committee sort of have a discussion around what would be the critical outcomes for that, and then that transition into the review period. Because I feel like at least some of the recent debates and discussions on new disorders have suffered from us not agreeing on, okay, what is that definition of a critical outcome to weigh the benefit on? Thinking of our recent discussion on SMA, and Beth in her summary talked about, if you're going to measure this on survival, there's one view. If you're going to measure this on improvement of motor function, that's another view. And so was there any discussion around in general, a definition of critical outcomes and how to measure?
Yeah, so Scott, thank you very much for that question. So one of the recommendations that Dr. Schoeneman made that came out of some of the grade work was that the process have a hierarchical list of important outcomes. So you can imagine a list that would start with morbidity and then maybe have, again, I'm just putting this out for examples, quality of life, motor development, intellectual disability, those kinds of things, that would be a standard set of important outcomes that would be looked at for each condition, and again, that there'd be a hierarchy of importance. And then before the review process began, that list in partnership with the advisory committee could be realigned based on whatever the unique aspects of the particular condition are. So there are a bunch of different ways of doing this from a process perspective, and I think that's something that we'll just have to dive into in the subsequent meetings. But the point that you're making, which I think had universal agreement, was that the important outcomes need to be determined before the review process commences so that it can really stay focused and not drift into something that may not ultimately be relevant for the decision-making process.
Thank you, Alex.
Yeah, now I'll just add that I certainly agree with what Alex said, and Scott, I think you brought up a really good point, and I think that if we do this as part of working with the evidence review work group and setting what critical or important outcomes are, then we could evaluate the strength of the evidence in terms of net benefit for each of those critical or important outcomes, and I think that would help us standardize the approach as well as get have those already settled before we start and make the discussion and the decision much easier when the evidence review is completed. Scott, did you want to add additional questions at this point?
No, I'll shut up and let other committee members talk. I'm sure that many people have similar thoughts. I'll come back. I'll raise my hand again later. Okay,
thanks. Sue Berry.
Hi, this is Sue Berry. Thank you, Alex, and the group for developing this process and continuing to help us think about the right way to do this. I'm going to take us a whole step back and ask kind of two things that it will help me to know better where you're going. The first one is that the general principles that have been used to add conditions have typically sort of followed roughly the general assessment that you have a disorder for which you can have an impact in health that has a good test and an efficacious treatment. And I was wondering if the fundamental parameters that newborn screening has long been based on were at issue here, as in do an intellectual disability panel and you might find a bunch of stuff. And the second question, it related but not quite as aggressive perhaps, is the temporal quality of intervention, which is that because we have a public health mandate for newborn screening that every child receives as a neonate, what are we doing about considering what happens if the temporal sequence of impact is not the neonatal period? We've already kind of stumbled into that with things we've approved recently, and I think if we're going to do that on a regular basis, we need to have a much better plan for how we deal with the idea that we set this up as a newborn screen because of immediate neonatal impact, and some of the things that we may well wish to tackle are not going to be neonatal in onset. So with that, I'll leave it. The two questions are, have we changed our fundamental assumptions, and are we sticking to our let's do this in the newborn period rule?
So I'm going to, again, thank you for those questions. I'm going to probably be able to answer that in a combined way. So the easy answer to your first question is no, this is not a change in perspective. Ultimately, recommendations are based on whether newborn screening leads to meaningful impact on health outcomes for the individuals being screened. So that fundamental approach is not being challenged. The issue is how do we do a better job of synthesizing the evidence to make that story. In terms of your second question about whether about screening for something that may not have benefits until many years down the road, that's not really a question for us in terms of evidence review, but what I will say is that in the evidence review process, what we would look for is whether evidence that newborn screening led to better outcomes than case detection outside of newborn screening, however that might happen. So the weight that the advisory committee might put on outcomes that might not accrue for many years is not within our purview, but what is in our purview is we will continue to look at whether or not newborn screening leads to better health outcomes than how things might happen with other usual care. Does that answer your question?
Sort of, but I think we'll have a continuing discussion about this because this has been, I think, on many, this is Sue Berry again, on many of our minds as we sort of ponder the decision, which is a very difficult one about adding new disorders. So it's going to be, I think, very careful. We're going to have to use our resources that are available to us very wisely and always consider the impact on the system as we make changes and add new things.
Yeah, I agree.
So, Sue, stay tuned. I think the first presentation after lunch will potentially address some of the questions that you raised related to some of the more recent conditions that we added to the RUSP that added different features, which included later onset disorders.
This is Sue again. I think one of the other things that hopefully we'll discuss is one of the impacts we have when we sometimes just don't know what we're adding, and we find out essentially afterwards the impact of some of those decisions, particularly with regard to late onset disorders. And so I know that there are other avenues that are also being discussed to try and thoughtfully manage not throwing the baby out with the bathwater, being able to do a screen that's impactful in a neonate, but also may have longer-term consequences. So this is the right time for us all to be discussing this. I'm pleased we're doing so. Thank you.
Great, thank you, Sue. Next is May Baker.
Oh, yes, my very quick comments back to the first question. Besides Alice and Dr. Burkey talk about why we trying to do predetermined critical outcome. The one thing I want adding on, if I recall, is we also want this become more objective. So before you do you already defined the pyramid. I just want adding on this one.
Yeah, thank you.
Okay, we have Anna Marie Saarinen apparently is in Mongolia and is listening in, but cannot get online. So she had a question. Has she been able to type it in?
No, so Anna Marie, if you can email me your question, we're happy to read it in.
Oh, can you guys hear me?
So anybody else? Scott, you want to? You can be up for the next question if you have additional questions.
Sure. So hi, this is Scott Schoen. I guess my question, first of all, I really appreciate Sue's comments and questions around sort of the science and the benefit of the discussion. A lot of at least my initial response to your presentation, Alex, is probably more around process at the moment while I digest it. And so you delve into a little bit the decision matrix, I mean, I'm interested to hear the elaboration on the potential for adding resource implication and sort of this idea of provisional is it was just a line in there, so I'm really eager to hear more about how that would even work or what that would look like. But I think about, and I don't want to say it's an addition to the decision matrix, but it's sort of on that side of the public health systems impact. It doesn't necessarily have a role in overall the decision, but it sounds like maybe this resource implication or impact could get at that. So what I'm wondering is, some of the challenges recently and some of the feedback from the community and the system has been that disorders end up at different places on the matrix, but the outcome is always the same. And so are there plans to look at, instead of putting a disorder or review in a decision matrix bucket and then debating whether or not it goes forward, having some consensus or an agreement on these positions in the matrix would generate this outcome, and focus our discussion on whether or not the review merits which bucket on the decision matrix, so that that process is now uniform going forward.
Yeah, I mean, I was just thinking in terms of the March Madness analogy. I appreciate you allowing me to make an extra point about that, which it's going to require a lot of additional conversation. So there is this conversation about whether or not the decision matrix, where you land up, where you end up with is directly tied to a specific recommendation, or whether or not the decision matrix is a tool that's used to facilitate conversation and debate, but maybe is not necessarily directly linked to what the final recommendation is. And that's going to require a lot more conversation than what we could do at this review. And then there was a lot of conversation about, in terms of the resource issues that you brought up, about considering what's required for long-term follow-up and whether or not long-term follow-up is even available, because if it's not, then it's a challenge to get the the benefits that you hope to get out of newborn screening. So although this may be dissatisfying to you right now, we recognize all the issues that you just brought up, and it's just going to require some facilitated discussion across the advisory committee about how that decision-making process is going to work. And as somebody whose job it is to put forth the evidence, I also don't want to drive exactly how you all use that evidence to drive decisions. So I think that that's just going to have to be an important topic of conversation.
Okay. No. Hi, this is Scott. So no, I appreciate that, Alex, and I'm glad to hear that at least there's contemplation around that, because you're right. I mean, that's the and I don't know that I feel one way or the other, but I agree it clearly requires more than a day or so of discussion around how to best land on that process. And I completely appreciate, having heard you present these evidence reviews many times over the last several years, that you don't want to be you don't want what you're saying to be that you're not engaged in the assessment, but providing the evidence, but providing an overall review of what evidence is out there. So I can appreciate the balance you're trying to strive and achieve, but the need for, I think, the committee to realize what and how are we to take all of that in and assess across each time a new disorder comes up. So I appreciate your response.
Thank you.
Great. So, Alex, before you get too far into March Madness, I just want to let you know that LSU is in the same bracket as Duke. So you can just leave it with that. So next is Sue Berry.
Thanks. This is Sue Berry again. I want to just toss out there, as we're talking about this, particularly with regard to the question about provisional approval. Part of we're really talking about the evidence review, but you're also talking about process. And I think it's also the time for conversation about the process by which we add conditions. I think many of you have heard some of the conversation that we've been working on at the Newborn Screening Translational Research Network to think about some strategies that might allow us to thread this needle a little more carefully by having some type of provisional approval that would allow us to study, understand, and make a better final decision regarding an addition of a new disorder. I'm going to throw that into the mix as an added complicating but possibly helpful feature, as something we can or may wish to consider as a part of our improvements in process. I'm hoping if Mike is on that he might want to add a few more words about that, because there's a lot of good reasons why that might help us do a better and more responsible job in adding disorders.
All right. Is Mike on the line?
I am. I'm pondering which part did you want me to focus on, Sue?
I think if you'd be willing to just talk a little bit about the process we're trying to go through, about how we can facilitate the process and consider the possibility of a provisional approval or a pilot study format.
Yeah, I can touch on it briefly. I am supposed to talk about this at the April meeting, so I won't go into great detail here, but fundamentally it's all about a rare disease problem where it's very hard at a population level to generate statistically robust data, about most anything. It takes just enormous populations when you have a highly variable disease, which many of these genetic diseases are. It really gets challenging to think about the statistics. So what we've at least begun to consider is something, you actually have to cobble together a number of different approaches to the problem. The Orphan Drug Act, for instance, is a mechanism whereby drugs for rare diseases are incentivized to manufacturers to get them, into the healthcare system. And basically they get various kinds of tax incentives and things that incentivize them to develop these drugs. They get a 7 or 8 year monopoly on sale of the drug. But I think the unique thing about it is that it takes advantage of an FDA, a broader FDA policy that allows for provisional approval of something followed by what CMS would call coverage with evidence development or required sort of data sharing from the studies that are going on in the context of drugs. It's post-market surveillance. In this context, it would probably be coverage with evidence development, whereby you were assured of getting paid for services to asymptomatic people while you're trying to figure out whether it's going to be added to newborn screening or not. There's lots of risk-sharing models out there. I think Annie Kennedy referenced one when she spoke, which she provided for public comment, which was a public-private partnership in the pre-competitive space where industry brought money generically to the problem, although in that context it's really around Duchenne. It's a much bigger problem with the pipeline of things coming. So there's lots of different ways of thinking about expanding capacity and improving our ability to put things into newborn screening, capture the kind of data that really should drive the advisory committee's decision-making process, which, if it was more robust, would certainly be for the better, and would not be that model of, that happens often with rare diseases where it's just get me one positive and we're good to go. I think that's good enough to go into a prospective process that's well organized and controlled of data collection. So I mean, there's a combination of things that one might think about, and we'll talk about them in more detail at the April meeting.
All right, thank you. Next, we do have an email from Anna Marie that Catherine has.
Sure. Hi, this is Catherine Riley. So I am reading this on behalf of community member Anna Marie Saarinen. She wanted to let folks know she appreciated the question that Sue raised, and was thinking that the answer that Sue was looking for was less about outcomes and more about how to find out if the matrix will account for things that can be picked up through newborn screening that may not have a clinical impact in the newborn period. The second comment is that she's very happy to see there was some thought given to panels or emerging screening methods, such as genetic or whole genome sequencing and things that would cover multiple diseases and disorders. So I wanted to put those into the record, and if there's anyone who wants to respond.
All right. Thank you. So next is Cindy Powell.
Hi, this is Cindy Powell. Can you hear me?
Yes.
Hello?
Yeah, we can hear you.
Hi. So thank you, Alex. I just wanted to comment on Sue's prior comments about this idea of provisional approval. I think as a member of this panel, we spent quite a lot of time talking about that, and as committee members, we know how difficult it is often to make a decision based on fairly, short-term follow-up that's available on some of the outcomes that we're assessing. And I think the idea of, a provisional approval versus having a method of putting something on the RUSP and reassessing it as more data comes in is was an important thing that we thought about, and whether kind of one versus the other. I think that one of the dilemmas is that, often you can't get that population data without doing population screening and having a state, begin doing population screening for a disorder unless it is on the RUSP. So I definitely think that's going to be a challenge going forward and something that, I look forward to discussing more in the future. Thank you.
Thank you, Sydney. Are there any additional questions or comments from committee members or org reps? None?
Dr. Burkey, can you hear me?
Yourself?
Hi, this is Susan Tanksley. Can you hear me?
Susan Tanksley.
Yes, Susan. We can hear you. Go ahead.
So I was wondering if there was any word on the Newborn Screening Saves Lives Act and the possibility of the time frame for the evidence review being removed from that. I mean, I know that influences the quality of the evidence review itself and, rushing through that process. So I was just wondering if anyone had heard anything about the potential change of that law, because I think that impacts this process as well.
So the committee charter is up for review, but obviously we cannot participate in that discussion. So we have not heard a thing. All right. Are there any other questions or comments? All right, Alex, thank you so much for putting us on track here, and I look forward to the next meetings where each of these items are going to be fleshed out in more detail with input from committee members and then ultimately to the final decisions on how to go forward. And the whole process is really designed for us to really take a good look at what we're doing and based on our experience, refining things in such a way that we're using the best approaches to evidence review and the best approaches to making our decisions going forward. So I want to thank everybody for their participation to bring us to this point, and I know there's a lot of work going ahead, but I think the product is going to be really strong for the committee, so thank you all very much. So with that, it's time to break for lunch, or for those of you on the West Coast, a late breakfast, I guess. We have a half an hour, and we'll be back here straight up at noon Eastern Time. So thank you all. We'll get back shortly. Thank you. Good afternoon or late morning to everyone. We are ready to start the afternoon session of the advisory committee meeting. To begin, we'll need to again take roll. So we're going to start with committee members and then go to organizational representatives. So Kamala Mistry, May Baker.
Here.
Susan Berry.
Here.
Jeff Brosco.
Here.
Great. Carla Cuthbert.
I'm here.
Kelly Kiln.
Here.
Joan Scott.
Here.
Cindy Powell.
Here. I was also here for the morning roll call and just having problems with my muting.
All right, thank you. We got you. Melissa Parisi.
Here.
And we'll wait to see whether we get another email from Anne Marie Saranen, since she can't get on the line from Mongolia. Scott Schoen.
Here.
Beth Storini.
Here.
And Catherine Riley.
Here.
So Robert Ostrander.
Here.
Great. Deborah Friedenberg. Michael Watson.
Here.
Deborah Friedenberg is on.
Okay. Deborah is on. Okay. Jed Miller. Susan Tanksley.
Also on. She's on mute. Sorry about that.
Okay, so Susan is on.
I'm here.
Okay, good. We thought you weren't going to talk to us. Chris Kuss.
She's also on.
Okay. Natasha Bonham.
Here.
Rebecca Abbott.
Here.
Kate Walsh-Bockley.
Here.
And Sean McCandless. Okay.
Dr. Burkey, this is Catherine. I just wanted to read into the record, too, that Chris Kuss was on this morning. I'm joined shortly after roll call.
Okay. Thank you. All right. So for our next presentation is entitled Analyzing the Impact of Adding Conditions to the RUSP Drafting and Approach. So another task Dr. Kemper and his team have been assigned is completion of a retrospective analysis on how implementation of screening for new conditions in the last decade has gone and what the impact on public health programs has been. For example, we have estimated time frames for implementation. Have they been accurate? Have the barriers and challenges that we have expected been what was faced, or whether there were different barriers that programs ran into, and whether there were findings or barriers that were not identified during our public health impact assessment component of the evidence review. And as mentioned earlier today, we have added some conditions with late onset, and we certainly want to have a better understanding of the impact that they have had on our public health systems. So our focus for this review is how each of the conditions added to the RUSP in the past decade has impacted the newborn screening system. So today, Dr. Kemper will present an outline for this report, and we are looking for input from the committee on the overall approach to the review and the contents of the report. So, Alex, are you on board?
I am on board. I hope you can hear me. There's a little bit of a bracket. I just want to see that come across in the transcription.
Okay. All right, go right ahead.
So with that, what I am going to present today is not the findings of the report. So if you were hoping for that's not what's in this section. Instead, we're going to be talking about the outline for the presentation, or for the reports around the conditions that have been added to the RUSP. So our charge is to review severe combined immunodeficiency, critical congenital heart disease, Pompe disease, mucopolysaccharidosis type 1, and X-linked adrenoleukodystrophy. The reason these conditions were selected is because of our these were the conditions that were added to the RUSP between 2010 and 2017. But in addition to learning the things that Dr. Burkey talked about before I got on, as a secondary goal, we really see this as an opportunity to think about things on the conditions that we're going to be looking at in the future related to implementation and outcomes. So I think there's going to be a lot of lessons that we can learn from this review process. One of the things that I want to highlight is that, oops, I didn't mean to do that, is that the review of SMA is a separate task order, and we'll address a few additional questions, and I'll describe that as we go through. And this is a special request that came from the Secretary of HHS in response to the recommendation from the advisory committee. So this is just a historical reminder of when the conditions came in, and I spoke a second ago about how SMA is a different, somewhat different report, although many of the are the same. So there it is. See, SMA will be reviewed in a different report. So what I did want to do is just spend a few minutes just talking about where we are in terms of implementation of these conditions, and some of these graphs that I'm going to be showing you are courtesy of New Steps. So thank you for these Team New Steps, and you could see that all states now screen for SCID, and states are still getting, fewer states screen as you go to the newer conditions after CCHD. This is another way of looking at the trends in uptake of these new conditions. You can see all states screen for at least one or two of the new conditions, and it falls off by the time you get to 6. And I've gone ahead and listed out the state newborn screening programs that screen for 5 or 6 of these, just in case you're interested. This slide shouldn't be a surprise to people that it takes time to add a condition to the RUSP, and so the longer amount of time that's elapsed, the more likely that a condition has been added to the RUSP, and you can see that SMA is still in early days. So in terms of the scope of the review, we are going to look at state implementation, public health implications, and clinical outcomes and impact, of course, where those data might exist. We have several guiding issues, actually probably more than several as I look at all the bullet points, that are that we're going to use during the review process. So we're going to be interested, and again, these are things that Dr. Burkey highlighted, but knowledge about the condition and gaps in understanding when the condition was added to the RUSP. So, what was known at the time, status of newborn screening implementation and related long-term follow-up services over time. Again, the advisory committee has repeatedly made the very important point about the need to understand long-term follow-up. We're going to look at specific conditions related to the condition, factors within newborn screening programs that impact the decision whether or not to add the condition to screening, contextual factors that may be barriers or facilitators, including things like what's going on with public health overall, the availability of grant support outside of the newborn screening program, advocacy activities, involvement of payers, clinicians, and others, availability and accessibility of healthcare services after the diagnosis. So, again, speaking to issues of long-term follow-up. And then one of the things I think is going to be particularly interesting is the changes in understanding of the condition that's evolved over time since newborn screening started, because we're all well aware that once screening begins, our understanding of the condition rapidly expands. So I did mention before that there are going to be some additional key questions for spinal muscular atrophy, and again, these were questions that were guided by the request from the Secretary. So specifically focusing on what activities have states undertaken to implement screening, what's known about the clinical outcomes of infants who are treated early, and what's known about the potential harms for infants diagnosed with SMA. Again, these questions come directly from the decision letter. So we have a standard approach, and I'm just going to outline this from a high level. For spinal muscular atrophy, we are going to put together a technical expert panel who can help us understand where sources of data might be and important additional issues for us to consider. Across all the conditions, we're going to be obviously looking at the previous report and outlining questions that the advisory committee had at the time that the decision was made. We'll be doing targeted interviews to understand issues of implementation. We're going to update the literature review, so going back from the time that the review was completed until the present, specifically looking at those key questions I talked about before. And then, of course, we will look for unpublished evidence that may inform our understanding about what happened after the condition was adopted. So, oops, I probably went too far that way. Again, we're going to have a series of reports for each condition, and like I said, SMA is going to be a little bit different simply because of the short period of time that's elapsed and the specific questions that came from the Secretary. Boom. Now I can move there to questions.
All right, thank you, Alex. This is now presentation open for questions and comments. Operator, please open the lines for the committee members and organizational representatives. We'll have committee members first, and then organizational representatives will follow. Again, a reminder to please use the raised hand feature on the Adobe Connect when making comments or asking questions, and when speaking, please state your name. So first is May Baker. May?
Thank you. This is May. Alex, I just want to ask a little bit, well, comments or questions. So you present the figure from New Step indicate how many states implement. I'm wondering, can you also include the one before this one?
That one?
Yes. So I think if there will be even have more information if you have another one to indicate how many babies impact. Because,
oh, that's a good idea.
Right? Yeah. So that's my comment.
Yeah, to give a sense of the overall public health impact across the country.
Yes, the people affected, like New York, California, they're much larger. Even so that's a two-way to look at that.
Okay, that's a good idea. We'll talk to New Steps about that.
Next, we have Robert Ostrander. Robert?
Yeah, hi, Alex. I just wanted to bring up something that the follow-up and treatment work group's been talking about the last couple meetings, and I think everybody knows, and that is the notion that longitudinal, I think we're trying to switch the word to longitudinal. The notion that there ought to be something in place for longitudinal follow-up, even if it's just an architectural draft, at the time that a condition is added to the RUSP. And to that end, if retrospectively you could see a place for longitudinal follow-up for these conditions, and it would be real cool to know when did that kick in compared to when it was implemented. I think we would find that very useful, and perhaps the committee would find it useful if they decide to implement some of our suggestions about making some infrastructure, or at least, again, an architectural drawing, if you will, having that in place before addition to the RUSP, part of one of the conditions.
Yeah, that's a good point. I really like your term, the sort of architectural layout for what, and I'll adopt your words, longitudinal follow-up ought to look like. And thinking back to my earlier presentation, that's a notion that we should keep track of.
All right, next we have Jeff Brotzko.
Thank you. Actually, Bob sort of asked my question, so I'll have to use this opportunity to say you look very professional in your photograph, Alex. I didn't recognize you.
Well, thank you very much. That's my stand-in model.
Yeah, exactly. And maybe broadening Bob's question a little bit, how do you see this work as fitting into, you've been part of this for years, the long-term follow-up for newborn screening. Does begin to answer it, or is it really, you're very much focused on the outcome from being added to the RUSP? How do you see this fitting into the broader questions of states and others doing long-term follow-up?
Yeah, obviously they're complementary, and the ability of us to find evidence for this report is going to hinge on what sort of long-term or longitudinal data are out there. But in my mind, although I'm open to change things based on what you all think, is that this would help us better understand the impact of the decision-making process and how well the report anticipated the issues that were going to happen downstream. But clearly, it's also going to address the issues that I think you're pointing to and May was alluding to as well in terms of, what was the impact of this on the health of the babies that were born during this time. Does that make sense? Did I answer your question, Jeff?
Yes.
Okay.
All right, next we have Scott Schoen.
I'm good. I put my hand down. Alex mentioned the answer to my question, his response to Jeff.
Okay, Sue Berry.
This is Sue Berry, and I'm very interested and, again, pleased by the sort of confluence of the things we're discussing here, because it's pretty clear that these all feed into each other in terms of ability to add new studies and then decide whether we've done the job we needed to do. I think everyone, I'm kind of a broken record on this point, but everyone knows that we have not really fulfilled our responsibility to the kids to start with, not just SCID, CCHD, POMP, and so on, but to all of the children without that longitudinal follow-up being part of what we plan. And so I'm hoping that our work on the long-term follow-up committee will have some impact in terms of creating some infrastructure and planning for long-term follow-up, or we won't be doing the whole job. And so as we move forward in doing matrix decision rebuilding and considering how we add new disorders, if this isn't a part of it, then we're not going to get anywhere. The more editorial comment than a question, but one thing I would point out was that our public commenters on DMD clearly took that responsibility head on without even being asked to, but know that it's necessary by telling us about what their plans are for long-term follow-up. And I'm hoping that we will continue to see that emerge as an expectation.
That's a very good point, Sue, and I think that that's why we wanted input from the committee, because the goal for this was not just to determine how many states and how long it took those states to begin to screen, but to really have an impact on the state public health system as well as the children being screened, and so that does include long-term follow-up. So any specific thoughts about how to incorporate that into this review would certainly be helpful to Alex, and what other things the committee would like to see from this review, if it's possible to get it from states, would be really important. So we can use this to help fill out some of the questions that we've all been asking. So next I have Natasha Bonham.
Hello, this is Natasha. On this slide, Alex, my question, I guess I have two questions. One is there a definition of what pursuing implementation means? Does that mean there's legislation happening? Does that mean the state is pushing for that, or advocates are pushing for that? Do you have any idea of what that kind of blue means?
Oh, I should probably, because I don't have the definition in front of me, and make sure that I don't know if anyone from New Steps is on the phone to answer that question directly. But I think it's more than just, and I shouldn't say just, it's more than advocacy work. My understanding is it was either pursuing legislation or actually doing something within the lab. But I could be wrong about that, so I don't know if Marcy Sontag is on the line that could answer that.
And maybe we can get that answer later. I think that just would be helpful to give some sense of what that really means in terms of how close or far things are in terms of whether it's in the legislature or it's in the lab or there are pilots or what that would look like. So
Yeah.
I think that would be helpful.
And I can promise you in the full report, we're going to have that like fully fleshed out.
Great. And then just to add on to a lot of the things that have been said, I think this piece about follow-up is really important, and particularly, and again, I don't know if that would be under the purview of this work or other work, you know, what is the loss to follow-up? So not just what's happening for those kids that we have the tracking of, but are we able to account for every single screen and every single identification? I think would be helpful so that we can see, you know, how is this full system really working as these conditions are added. So that's my 2 cents on the follow-up side. But thank you.
Thank you.
See, is Marcy Sontag available on the show?
Julie.
Oh, Julie, okay. Let's see if we can open his line. Julie,
He's open. He's open.
okay. Jalili? We can't hear you. Are you on mute? We've been told your line is open, but we cannot hear you. All right, well, let's see if we can get that straightened out. But in the meantime, we have Sue Berry.
Hi, this is Sue Berry again. I am interested also in the yellow bars where things are not screened, and some of the assessments are sort of general categories for why people are struggling. I know that in some cases it means it's because they have to have legislation, and that's an onerous process. I know it's sometimes because they don't have the equipment or wherewithal or knowledge base to implement a specific screening strategy. I know that sometimes it's because the programs, even if they want to do, simply don't have the financial support or ability to add on an immediate basis. So a couple questions. One is, are we surveying some of the reasons for that? I'm pretty sure New Steps has some of that kind of information.
Yeah, no, that's definitely part of the, you know, the barriers and facilitators of screening that we're going to try to collect. And that's, you know, for our targeted interviews, because it can sometimes be hard to get to those issues.
Yep, definitely. And then the other thing is has any, just throwing this out, and this is not necessarily a purview of this discussion, but one of the possible solutions for some of the strategies is to stretch our boundaries as far as what we consider to be state-supported screening, and seeing if states can't come together when technology is an issue to help support some of those things. Because, you know, we already have some precedent for that kind of activity in states that are small, contracting to other laboratories. So just thinking about some feasibility strategies, I'm hoping that's one of the things the group will identify is mechanisms for overcoming some of those barriers.
Excellent.
All right, next, Melissa Parisi.
Thank you. This is Melissa Parisi from NIH. A comment and a question. Alex, I'm hopeful that there will be some opportunities to utilize or at least explore some of the data that are in the long-term follow-up aspects of the longitudinal pediatric data resource that's part of the Newborn Screening Translational Research Network, because I think that may be helpful in terms of trying to discern some of the outcomes for these newer conditions, particularly for SMA and some of the others as well. But I also was wondering if in the course of your work you might have an opportunity to explore some best practices for longitudinal follow-up, given that there are going to be different strategies employed in different states and different screening systems, and whether there might be some lessons learned that might be that might come out of this work.
That's a really interesting idea that I hadn't thought about in terms of not just long-term follow-up per condition, but what are the generalizable lessons across the various conditions? That's a really, is that what you meant Melissa?
Yes, absolutely.
Yeah. That had not occurred to me before, but that's a really good idea.
Okay, we have an answer texted in from
Yes.
Marcy.
Hi, this is Catherine Riley speaking on behalf of Marcy Sontag, who sent in an answer, so she's in listen-only mode, that the activity by the public health program may be legislation or working with an advisory committee or seeking fee changes or getting new equipment, and that we'll be hearing in the future more from APHL on this at a future meeting.
Okay, great. So even though I went to the rim of my knowledge, it turned out my answer was right.
Well, some people are lucky, so that's good. Michael Warren.
Sure. So this is a question that goes back to a little bit about what Dr. Berry was asking. I'm curious, as you all, Dr. Kemper, are approaching this, it's described as a review, whether there will also be some recommendations. And in particular, I'm thinking about, as you're looking at some of these contextual factors that are barriers or facilitators, states often rely on limited funds to be able to stand up these services. And I think, for example, about what they get from our maternal and child health block grant. Mm-hmm. And if there are duplications of efforts where there might be some economy of scale, if you see that as you're thinking about those barriers and facilitators, us knowing that would be helpful as we think about future funding opportunities or recommendations in the event that we're ever asked about how we might structure funding opportunities. Looking for those might be helpful if you see those in your review.
No, that's great advice, and we will certainly make sure to explicitly look for that.
All right, now we have a comment that was emailed in by Dr. Joe Schneider.
Hi again, this is Catherine Riley speaking on behalf of Joe Schneider, who is a work group member on the follow-up and treatment work group. And it's in response to Alex's presentation that CCHD may be implemented in all states, but the implementation is variable. In at least one state, there is no adequate public health reporting to understand whether it is being appropriately and adequately done. In essence, in this state, the legislature simply gave a mandate to the hospitals to do CCHD screening, but never funded the reporting mechanisms to ensure compliance.
Yeah, that's I completely agree with Joe's comment, and that's something that we'll need to explore. The limitation around the data systems for CCHD and the fact that it's a point of care screening test really make these data collection issues challenging but important. So that's something that we already plan to look at.
Okay, are there any other additional comments or questions from committee members or org reps?
Scott Schoen.
Scott Schoen. Scott.
Hey. Yeah, so hi, it's Scott Schoen. So I just wanted to say that, Alex, I think, your slide about guiding issues, you had a bullet point, something to the effect of contextual factors that served as barriers or facilitators of adoption. And you talked about public health activities, grant support, there it is, advocacy, involvement of payers, involvement of clinicians. I would suggest that talking to states that haven't added it to assess, perhaps there aren't actual barriers, but just a fundamental disagreement with the addition of the condition to the RUSP, and get a sense of the feeling within the state and their advisory committees, that, around just their general feeling about the addition to the RUSP. So I don't want, some of this presupposes that everybody should add it because it's on the RUSP, but again, it's recommended, not required uniform screening panel. So I just want to make sure that we capture that.
That's a really, really good point. Thank you for adding that in. We'll make sure we do that.
All right, next is May Baker.
Yeah, it's a follow-up Scott Schoen's comment. This is May. Actually, Wisconsin in this category for two disorders, MPS 1 and XLD. The committee evaluated and discussed it. The decision was made because the benefit risk and potentially the problem, especially for XLD, the decision was made not at this time.
Mm-hmm, mm-hmm.
Thank you, Meg. Who else?
I don't see anyone else at this time.
Okay, no one else. Any additional questions or comments? Last chance. All right, Alex, thank you again for a nice presentation and a project that I think is going to add considerable information to inform subsequent decisions for us. And so I think this is going to be really helpful.
Well, thank you. Thanks to everyone for their feedback. This was really very helpful.
All right, thank you. Good luck in your bracket.
Who needs luck?
All right. Next, we have a panel discussion, so I'll give you a little background. During the past year, this committee has had several discussions about what potential resources might be available for studying rare diseases and what data resources might be available to help inform the committee with regard to conditions nominated for the RUSP. We were also interested in knowing more about the data available to help us assess the impact of adding conditions to the RUSP and whether additional data sources are available to states to assess long-term follow-up and outcomes. This is also a timely topic for the committee as we embark on assessing the nomination evidence review process. So we put a panel together today entitled Resources for Facilitating Rare Disease Research. This panel will provide us with an overview of the resources available at a national level. This will start the conversation, which we plan to continue in April with an additional panel. As we hear from the panelists today, please be thinking about how the committee may be able to help, perhaps by encouraging research on rare diseases in the development of additional data resources, as well as identifying ways to have more synergy between the resources already available. At the April meeting, we will hear from disorder-specific rare disease foundations and/or registries about their experiences in developing and implementing registries and the types of data generated that potentially could help inform the committee or states with long-term outcome data. I'm going to introduce our three panelists now, and after each one has presented, we will then open up this for questions and discussion. First is James O'Leary. Mr. O'Leary was formerly the Chief Innovation Officer at Genetic Alliance. He has worked with national public health systems, disease-specific organizations, and community groups to improve access to genetic services, engage consumers in national policy setting, and institute legislation that protects the public from discrimination. Our next presenter will be Tina Irv. Dr. Irv is the Program Director for the Rare Diseases Clinical Research Network, a multidisciplinary international program in the Office of Rare Disease Research. As the lead for the Rare Diseases Clinical Research Network, she collaborates with 10 NIH institutes to manage 22 consortia and a central data management coordinating center. Lastly is Vanessa Bollinger. She is the Director of Research at the National Organization for Rare Disorders, NORD. In this role, Vanessa oversees the management of growth and implementation of NORD's research and scientific activities. So I'm going to start by turning this over to Mr. O'Leary. Operator, would you open Mr. O'Leary's phone?
And Mr. O'Leary, this is Catherine. You are in presenter mode, so you should be able to advance your slides.
Oh, okay, great. Can you hear me?
Yes, we can. Go right ahead.
Okay, perfect. Yeah, thank you so much for having me here today. It's good. I've really been head down writing lately, largely on what happens with patient data and healthcare systems, and so this is a good topic for me right now to speak about in a more global sense. I think everyone on this committee is pretty familiar with the need to accelerate rare disease research. But even in the last 10 years, I feel like the strategy has changed quite a bit. You know, a move more globally to attract attention and interest in the space, to rather be lowering barriers and promoting innovation in the space, which is frankly very welcome change. And I think that's true in support, it's true in clinical care, it's true in drug development and public health. And today, my task is to really just give an overview, get everyone on the same page, kind of on the range of resources that are available with a particular focus on registries and their diversity. So, okay, next slide. As the field has progressed, I think the resources have progressed as well. But like any space, maybe even more so in this space, the development is really decentralized. In the case of rare diseases, it's disease-focused, disease organizations, so researchers focused on a specific disease, public health professionals focused on a specific disease, or it's very institutionally separate. And that creates a lot of challenges to finding the time and resources to build broadly useful tools. And there are a lot of resources necessary because we're talking about a space with thousands of different diseases with very different indications. We have a speaker from NCATS, and NCATS did a pretty comprehensive process of collecting and collaborating between many organizations of many of these different types of tools and resources. So I'm not going to go into as many specific tools today, except in the registry space. But I will take a few minutes to talk about the types of resources that are available and the importance of them, and really bringing them all together whenever you're thinking about engaging people in this space. You know, first, the one we always think of is information. That might be kind of guides online. It might be, you know, web resources, you know, how-to guides, and that type of resource is valuable, but in many cases, lacking context, it can be incredibly challenging for people to use. What people need in combination with that is expertise, whether that's internal expertise, staff on hand, or it's external expertise, people to guide them through the process. And I think that's particularly the case, and we've seen that's the case around the RUSP, and helping people understand not only, you know, the importance of getting on it and the type of information that they'll need, but also really guiding them through the whole process of generating that data. Who to engage, how to engage, how long that takes, what the resources look like, that type of thing. I think tools and templates can also be incredibly helpful. Things that are plug and play, reduce the resources across many different types of conditions, from contracts to validated instruments to outreach tools. And then going further, which is something I'll certainly touch on in the registry space, platforms, whether that's open source software, registry platforms, et cetera. But they have to have sufficient capability and customization for the needs of the group in question. And they certainly take ongoing resources, which I think everyone in the newborn screening space gets. And then we can't forget about data. So whether that's access to electronic medical record data, which is an ongoing problem for everyone, whether that's samples, et cetera, and then investment, which is resources, money, and certainly in-kind services and partnerships. So I'll go through all of this in a little bit more detail in the registry space, but this is true kind of across all of the resources for accelerating rare disease research. The next slide is something, I think I sent this out ahead of time. It's called the Navigating the Ecosystem of Translational Science. And it's very much in the translational science space, it's in the drug development space, but I wanted to put this up as an example. This is something that I worked on at Genetic Alliance. I believe NCATS has a version of this that they updated as well. And when we produced it, it was to dispel the myth of the drug development pipeline. You know, you hear that all the time. It's a pipeline. You know, one step at a time to get to a drug, and that's just not real. In fact, it's this really interconnected process with which there are a lot of opportunities for problems, but also a lot of opportunities for collaboration. And the complexity of developing this was not to scare people, but really to show off those opportunities for collaboration and the need for simultaneous action. The same is true for screening and testing. Absolutely, and I don't know that I've seen a map like this in that space. The classic example is registries, which is if you wait to build a registry for when you need the data from that registry, you're going to be waiting a long time. And so these things have to happen in parallel. And we need to be thinking ahead on not only how can we use data that's available, but how can we encourage those sources of data to collect the questions that are relevant to us. And I think that's certainly something that this committee is interested in. So let's drill down a little bit more on registries. And we have limited time today, so feel free during the Q&A to ask me for more detail on this, because I'm really just going to give a high level to make sure that everyone's on the same page for the discussion. There are many ways, I think everyone's familiar with what a registry is, but there are many different ways to kind of slice a registry. There are many, many, many thousands of registries out there in the world, and I like to think about them kind of in the who, what, why, and how. So who is in the registry? Who are the participants? Is this a population registry? Is this a community registry? Is this a study-specific registry? So what types of data and samples are being collected? Are there biological specimens? Is this patient-reported data? Is it clinical reported data? Is it data collected from apps or from tests or with insurance companies? There's a lot of different data types that can be collected and useful. The why of the registry, which is perhaps most important, is it focused on natural history? Is it biomarker identification, trial recruitment, surveillance? Is it to promote a learning health system, identify clinical endpoints, public health tracking, to develop coverage policies, et cetera? There's just a huge range of uses of registries. And then the how. And this can be the most important. In fact, I would argue that this is most certainly the most important, which is both from how is the data collected from a data science perspective, but also how is outreach and engagement done, and how can you ensure trust and security to ensure the long-term viability of that process, of that registry. I've included some questions here that are the questions that I would ask anyone that was wanting to start a registry or to partner with one, to better understand whether there's a fit, to better understand what the goals are, and ensure that there is a viable connection there. So the first item is, what is the purpose of the registry? It seems obvious, but if the original purpose or lack thereof, which is a common problem, is that people are interested in the registry because it's the thing to do. But if there's not that match between that original purpose and the data that you need, there could be limited utility for things other than exploratory purposes. There's a lot of data creep issues with registries, so it's really important to understand what that purpose is, and if that purpose is changing, to look back at all the aspects of everything from the engagement strategy to the data models, et cetera. A lot of community-based registries, for example, or clinical registries have the ability for ongoing connection to participants. It's one of the advantages of registry. So you can kind of pivot and change direction, but it should not be taken lightly. The second question I would ask is about the types of data and samples to be collected, and much for the same reason. Is it a match? The third question is around who contributes the data and from where that data is collected, as I mentioned earlier. All of these data types, whether it's contributed by a clinician, it's patient-reported, or other, have their value for different types of goals and different data types. And there's been a lot of studies on the accuracy of patient-reported data, for instance, or the accuracy of data collected from electronic medical records. But the how of how that's collected is very important, and certainly whether that data is representative. Is that data longitudinal? In the research space, we are willing to accept a lot of bad kind of freeze-frame data because there's a less cost and it's easier to de-identify data. But that is, there's a lot more that you could do with ongoing connections between people and their data, and registries can provide that. National or international, it seems like a simple question. It is not a simple question in that there are a lot of kind of regulatory hurdles, funding hurdles, and ease of collection challenges that occur when you move from a national or to an international registry. But in the rare disease space, many times you do need to have an international focus. Similarly, how the registry is governed is incredibly important. I would argue that these days there's literally no excuse for a lack of community representation in the governance of a registry, and in fact broad representation, because that ensures the long-term viability, and it also ensures that the protocols that are being used are relevant to the community. Data ownership is incredibly important. Who owns the data? And there are a lot of instances where this is a very important question to delve down into, because there is confusion in cases of research partnerships on who actually owns the data. Is it the academic institution? Is it the government? Is it the organization, the community, or the individuals themselves? And most of this is about control. Ownership is a term that people argue about a lot in this space, but control of the data is what it really comes down to. And then how the data will be used. And that needs to be clear if you're going to maintain trust in a registry. The most important, though, and certainly for this committee and for the purposes here, are how does the data get to where it's needed most? And this is a really important thing when you're looking at any registry or any partnership with a registry, is to get this out of the way very early, because you don't want to get down the line, 6 months, 12 months down the line in a partnership, and then find out that there are data access issues, that the data can't actually be extracted in a useful way from a system. This is a problem that many, many people face with accessing electronic medical record data right now, and something a lot of people are trying to create solutions around. But this is something that frequently gets kind of ignored in the first conversations around this topic, and then becomes the biggest hurdle later on. So I'll touch just a little bit on the reality of registries. This is something I could talk about all day, but I included this cartoon here. I know everyone's reading the cartoon first, so I'll talk about that first. It's not just to talk about data quality or the question or the validity of the data instruments, but it's also just to say that we need to understand the context of participants' lives when we're looking at the data. Registries can be very, very good at that, but also they can leave out important context. Who gets to ask the questions in a registry really matters. I always say there's so much power in who gets to ask the questions. That's true of registries, and it's true generally in life. It's not just what gets included, but what's missing. And the reality of registries these days is there is just a massive amount of diversity. Registries, there are many, many thousands of registries. They're incredibly expensive to build and maintain. The costs of them balloon, kind of dramatically over time, and the way that registries have been funded is changing. A lot of registries external registries or community-led registries might have been funded through industry money in the past. Industry has been reticent to continue to fund registries because of the huge cost of maintaining them. So because of issues around how useful the data is, if the industry partner is kind of staying out of the question generation process, and how to maintain the neutrality of that registry, but also to ensure that that data that comes out is useful to all parties. There's been a move towards platforms to promote sustainability, to improve the technology, and comply with international regulations, but also to provide all the tools and resources that go around creating a registry. So, building a registry in REDCap is one thing. You have to kind of serve up REDCap and kind of generate that research database yourself, versus kind of more full service registries, whether it's Patient Crossroads, which is owned by Invitae, NORD has a patient registry, Genetic Alliance has a platform called PEER, which they just announced a kind of new partnership with Luna DNA. Those types of more full service served through platforms and in many cases participant engagement platforms provide a different level of service to registries. But it's very clear that this space is rapidly evolving and that there's just a huge amount of quality data out there. But it really takes looking with a closer eye at the registry, what data they've collected over time, how old the registry is, how it's funded, and where they're pulling data from. So I think lastly, and what's most relevant to this committee, is what direction is needed. And I think there's, in the public health space, in the screening and testing space, there's a huge need to identify what types of data are needed, the who, what, why, and how, or what groups are looking for. I remember years ago, I mean, it must have been 5 to 10 years ago now, we convened a conversation, I convened a conversation with disease advocacy organizations where they were specifically asking how to dovetail their registry initiatives with their desire to have their condition be on the RUSP or for a kind of USPSTF grade B recommendation. So groups have been thinking about this for a while, but there was a complete lack of information available on how to just go about that, about what types of validated questions to add to, what types of requirements and baselines were needed to get there. And it's more than just providing a list of those data types. It's providing guidance on, how to get from A to B. And doing so in a way that doesn't, guarantee that that will happen in a short period of time, but also explains that this is an ongoing process and that things need to happen in parallel. So when we get to that place, we have all the data that's needed and we can move faster. I think it's also about creating a neutral space for collaboration. Just as I mentioned with industry, it can be very confusing on how to, create a safe space for dialogue around what the appropriate question types are when you get down to disease-specific conversations. And so creating that space and an open dialogue around that is incredibly important. And then just where possible, to clearly define those questions and data types, to provide them in a way that, where possible, it can even be plug and play or things can be customized, can be incredibly helpful, especially when some of the most valuable data sources might come from community-led registries, which can be from organizations that range from very small to certainly organizations that are international and have multi-million-dollar budgets. So it's important to engage all those stakeholders, whether it's clinical registries, community-led registries, insurance and industry, to understand the full spectrum of data that's available or could be available. And so with that, I'm happy to drill down during the Q&A on any of these topics, and certainly you can reach out to me with any other questions. Thank you for having me.
Thank you for a great presentation to get us started, and I'm sure there are going to be some questions at the end. So thank you. Next, we have Tina Erb. Could we get her slides up and make sure her line is open? Tina, can you hear us? I can hear you, and I'm here. Okay, we can hear you too, so we're in good shape. Your slides.
Tina, this is Catherine. Do you want me to make you a presenter?
Yeah, that would be great. And sorry, my zebras look a little dark on this slide.
Okay, just give us 1 minute.
All right.
Okay, great. You should be all set.
Okay, great. Thank you so much. And I'm very happy to be back with my old newborn screening friends here today. And so the title, which you can't see, or at least I can't see on my screen, is Rare Diseases, Resources, and Activities at NCATS, which is the National Center for Advancing Translational Science. And I work in the Office of Rare Disease Research, and this is all at the NIH. So disclaimer, disclosure, presentation reflects the views of presenter and does not represent NIH's views or policies, and I have no conflicts to disclose. So when we think about a disease that has a prevalence that's greater than Alzheimer's disease, HIV, and all cancers, and almost equal to diabetes in this country, that would be all rare diseases combined, as they combine all cancers. So it's 30 million people that have rare diseases, and they're making it to be about 7,000 rare diseases at this time, and we've been adding 230 a year for the last few years. So that 7,000 is very much a growing number. So science has been advancing at breakneck speed, and there are enormous opportunities that have been happening. The Human Genome Project, we're curing cancer, and we're doing gene editing. So with those opportunities comes the need to deliver on the promise of science for patients. And it's not just the promise of treating these patients, but it's really a responsibility for us to be treating these patients. So we face a lot of challenges in the newborn screening or in the rare disease world. And those are, we have small numbers of patients, many disorders are poorly understood, phenotypic diversity within a disease, patients are geographically dispersed, there are few diseases, they're life-threatening, there's little or no clinical trial precedence, and they affect many children. So where are we with treatments for these rare diseases? Only about 95% of rare diseases that have been identified only about 5% have regulatory approval treatment. 95% have no treatment. So at the rate we're going right now at developing treatments, we're developing treatments for about 3 to 5 newly treatable diseases a year. So as the rate is growing, it will take us about 1,000 years to have treatments for all the rare diseases. And this is a challenge for us. So one of the things Ann Pariser and I did was we did this Ignite course through HHS, and we really talked to a lot of different people in the rare disease drug development field, and where we were looking at where some of the problems were and where some of the strengths were. And there are a lot of challenges that face us. And these are the same challenges that face the newborn screening field. So we have natural history studies are being done, but they're all done very separately. Everyone's on their own island, as we said. And there's not a lot of really good connection with the clinicians necessarily. And in developing the treatments, even at the NIH, there's not great linkage. And going over to developing an IND, this can be very challenging because a lot of the investigators on, say, the left-hand side of the universe don't have a lot of experience in the drug development side. And what we really need to do is develop pathways to link all of these things together. And if you think about it, what does this have to do with the babies? What does this have to do with newborn screening? A lot of what we have to get done for clinical trials to happen and for a drug to be accepted are the same things that we have to do to have newborn screening put onto the panel. You know, we have to have good understanding of the disease. We need to have a treatment. There needs to be good communication with families. So a lot of the challenges are the same. So I always think of it as there are multiple things that need to be happening at the same time. When you're developing a treatment for a rare disease, you also in parallel need to be developing a better understanding to get to a good screening tool that's been tested at the same time. So you don't find yourself with a treatment, but there's nothing that's been developed for newborn screening. So I've always been a proponent that these activities need to be happening in parallel. We all need to get the trains to the station at the same time, basically. So what's being done to address these many challenges? And today I'm going to speak a little bit about some of the things that we're doing at the Office of Rare Disease Research at the NIH. So the Office of Rare Disease Research, our responsibility is to facilitate and coordinate between multiple stakeholders in clinical rare disease community, including scientists, clinicians, patients, and patient groups. And so we've developed some tools, and we're also conducting some research. And I'm going to touch a little bit on both of these, but I'm always available to answer any questions you may have in these areas. So one of the programs we have is Genetic and Rare Diseases, our GUARD program, which was established in 2002. And GUARD's mission is to really provide comprehensive plain language information on rare diseases that is freely accessible in the public arena. And so if we break it down and see who's looking for information on rare diseases, find 37% of the people that go to this website are family and friends. 30% are patients, and we have 10% healthcare professionals, some students and teachers, and 17% of the people don't identify as to who they are. So one of the things that I think is really interesting is that if you look at who's been going to the GUARD site to find information over time, this has been increasing. And if you look at this is the users by month. We have over 1 million users going to this website looking for information on rare diseases every month. So there's a lot of interest. People are searching for information. And this is one place that they can go for it. And it would be great if we link some of the newborn screening information directly to our GUARD. And that's something that just popped into my head that we can make sure that there's newborn screening information in this resource as well. So we also have a new program, which is called RADAR, which is Rare Diseases Registry. We like acronyms in the government, so we came up with RADAR. And its mission is to develop an easy-to-use educational website that would enable new patient advocacy groups to adopt good quality practices early in registry development. And how this really came about was everybody wants a registry. We can't afford to build a registry for everyone, but we can teach people what they should have in a registry. So we can teach them to be good consumers if they're looking to work with some private organization, and we can teach them to be savvy builders when they're putting together their own. They're going to be able to ask the right questions to get what they need to have a registry that's not just a registry for the moment. I always like the hockey analogy, Wayne Gretzky's analogy of you need to be thinking of where the puck is going, not where the puck is now. In newborn screening and rare disease drug development, we need to be thinking of where we want to be 2 years down the road, 5 years down the road, 10 years down the road, rather than just in the moment of, let's build a registry. So our vision is kind of a registry in a box, and another analogy for you is if you give a man a fish, he'll eat one meal. If you teach a man to fish, he'll have fish for a life. He'll eat for a lifetime. So basically, we want people to build registries that will stand up rather than give them a one-time registry that can't be developed and doesn't grow. So the RADAR website is online, and if you just Google NCAPS and RADAR, and this should pop up for you. And what it does is it literally walks you through how to set up a registry, how to manage a registry, and about RADAR in general. So if you walk through it, and I'm not going to do it today, this is something you should definitely go and look at. It's how can you create your registry plan? How do you determine who should join? Develop the right questions for what you need, and decide how to collect and store the data. So if you look at the website, you'll see that one of the first things you need to do is set your goals, consider your constraints, plan for roadblocks. It literally walks you through step by step of what you need to know to develop a registry. And you can go deeper and deeper into the technology, as you want. You can keep clicking for more detailed information. So if you want your informatics team to go into it, there'll be information for them. Or if you're just a parent looking to, what should I know, what should I ask if I'm working with a company to develop a registry, this will help you walk through it so you can be a strong consumer. And so again, you can see how detailed the information can be, setting short-term registry goals and long-term registry goals. And they have this for all the different steps that you need to go through as you're developing your own registry. Again, to have an informed public or an informed rare disease community. Another thing that we have is the toolkit. And the RADAR is part of our toolkit. And so it's really, the toolkit was put together by patient groups to bring together the tools that they need to help advance medical research. The goal is really to ensure that patients are engaged as essential partners. So it's really meaningful that you don't just bring them in when it's time to go to the FDA, but you bring them in early. You ask them questions early and you involve them in a way that is meaningful throughout the drug development process and also in developing tools for newborn screening and understanding that. So there are tools for discovery, there's tools for prepping for clinical trials, and again, time is limited here today, so I'm not going to go through all of these, but again, I highly encourage you to go to these different websites to look at the detailed information that they've gathered. Clinical trials for FDA review and after FDA approval, what should you be doing? And this is a resource for family groups or researchers who might not be as familiar with this for them to use. And again, if you have any questions, feel free to contact me and I will get you to the right person in the Office of Rare Disease Research. Another thing that we're doing in the Office of Rare Disease is the Rare Disease Clinical Research Network. And this is something that was part of the Public Law 107-280 to establish rare disease clinical research consortiums of excellence. And back in 2003, they funded 7 consortiums. Over time, every 5 years, there's a new competition. In 2008, we funded 19. In 2013, we funded 22. Over time, over 31 individual consortia have been established. 238 disorders have been looked at, and there have been over 40,000 participants. So in 2018, we had, the applications came in October of 2017. We had our reviews in February, and we're right now in the process of deciding between 8 different institutes who will be funded for the next cycle. So what these rare disease clinical research consortium, what it's about is they're intended to advance the diagnosis, management, and treatment of rare disease with a focus on clinical trial readiness. And if I look at the definition of clinical trial readiness, to me, it's also newborn screening readiness. So each RDC will promote highly collaborative, multi-site, patient-centric translational clinical research with the intent of addressing unmet clinical trial readiness needs. So how the network is set up is we have multiple NIH-ICs that work together as partners. Each of these little honeycomb boxes is a consortium that exists right now, and a couple of these are looking at newborn screening. Jennifer Puck with the PID, the Primary Immune Deficiency Consortium, they're looking at newborn screening, and one of the things that we had written into the last RSA was to encourage people to follow up these babies who have been screened in newborn screening or work on developing something for newborn screening. Each one of these consortia consists of patient and advocacy groups, and the patient and advocacy groups have to be involved, as I say, from soup to nuts in a meaningful manner. There are research and clinicians that are involved, and the NIH is involved. So this is part of, it's a U54, so it's a cooperative agreement. So every one of the consortiums has a science officer from the NIH assigned to it that helps oversee it. And it's a group of program officers from NIH that meets regularly that talks about these disorders. The network is supported by a data coordinating center, and in the next round of the data coordinating center, what we're planning on doing is making the data that has been collected for the last 15 years and will be collected in the future more readily available to public using appropriate safeguards for the data and for the investigators and for the patients. We want to make this data that we're collecting more of a resource that's available for people to see and for scientists to use and have access to. So that's one of our activities. Another activity for drug development, and this is something that is going on in parallel at the same time that you guys should be looking at developing new tests for rare disease or for newborn screening, are our STTR, our Trend and Bridges projects, which really work on de-risking getting a clinical trial forward. So, we have the valley of death, as we call it, to get from the basic investigator over to a startup company. And so the Trend program works with groups who are trying to move from the lab to get to a clinical trial. And the Bridges program does the same, and you all have the slides. And again, if you want any more information, the very last slide in this set has the contact people for this. And as you can see, or perhaps not see because the type is very small, it's NCAT starts partnering with these groups at various stages of the drug development, and then they pass off the studies to industry once industry is ready for it. And how that's done is the data that they're collecting is rigorous and strong and can be repeatable. And that's one of the things that we're really trying to focus on in the RDCRN, to have strong data with strong data standards that will be attractive to move down the pipeline, that will be usable if you need natural history study for, adding something to the RUSP. So these are what these groups are doing. So again, if you guys have any questions, I'd be happy to answer them at the end. Thank you.
Thank you very much, Tina. We appreciate that. Another great presentation. Now we have Vanessa Bollinger. So if operator, we can make sure her line is open, and let's see if we can get her slides up.
Hi, Dr. Bollinger. You are on as a presenter, so you should be able to advance your slides.
Okay, perfect. Hi, everyone. Thank you very much. This is great. So I'm the Director of Research, and I oversee all the scientific and research work that NORD does. the National Organization for Rare Disorders, and I'm pleased to hop on the line today to share a bit about our registry program and our patient-centered research program. Looks like the slides are cut off a little bit. So I'll start with a brief overview, introduction to NORD for those who are unfamiliar. I'll go through an overview of our registry program and some of the growth and impact that we've seen since we launched. I'll talk through some of the registry partnerships that we've developed and our different models of engagement, and then share with you some opportunities to engage in different research studies or data resources. So a brief introduction to NORD. NORD's an independent nonprofit that is leading the fight to improve the lives of rare disease patients and families. So 2019 marks NORD's 36th year as an organization dedicated to elevating the voice of the rare disease community. We're a truly independent 501c3 advocacy organization, so there's no industry on our board of directors or on any of our governance committees. And we're fully funded by charitable donations, grants, philanthropy, membership dues, and by providing services. So our overarching strategic priority areas that drive and align NORD's cross-cutting programs are innovation, development, and access. And this slide gives a sense of where and how NORD's research work fits into the larger context of the organization. We have 4 programmatic areas: policy and advocacy. We work at both the federal and state level. We have a patient services program that we launched in 1987 that serves over 7,000 people annually. We have our education program that part of their purview is that they put on our annual summit, which happens each October in Washington, D.C. And this year we have a new conference that we're putting on. It's the Patient and Family Conference, which is happening in June. So I'll share a little bit more about that later. And we also have our rare disease report database that sits within the education department. And then the research department, we have 3 arms to the research that we do. We have research that we support, which is our registry program. We partner with folks to develop patient natural history studies. We have research that we help to fund through our research grants program, which this year is celebrating its 30th year. And we also have research that we conduct, which is original research and publications that NORD puts out. So to go a little bit more in depth about the I Am Rare registry program, this timeline shows some key milestones in the development of our program. So after a multi-year, multi-stakeholder planning process, we launched our first registry in 2014. And we've been fortunate to have early and then continued engagement with a committee of stakeholders, so folks from the NIH, FDA, community organizations, patients, researchers, clinicians, that really sort of formed the core committee that helped us design and develop our program to start. And then we've had continued engagement with those stakeholders throughout. And our intent is was to build a platform, a registry platform in a modular fashion, so to build a platform that was accessible to the full rare disease community, to keep the data ownership in the hands of the disease-specific communities, and then through partnership to build capacity and empower and support patient organizations to become data stewards and data experts for their communities. So our platform is intended to collect data to understand the natural history of rare diseases through patient-reported outcomes and patient experience data. So we capture information on transitions in care, disease progression over time, heterogeneity of disease expression, and really like quality of life and lived experience. So the ultimate goal really is to collect data to advance discovery and save lives, but our first goal is to collect high-quality data in a way that's not burdensome to the patient. So we really were intentional about how we developed our model so that it was easy to use and sort of reduce some of the research burden on the patient communities. So as I mentioned, we launched in 2014 with 5 pilot groups. We launched and we tried and tested and refined our model, and then we were fortunate to receive a cooperative agreement from the FDA in 2015 which was really intended to help us scale up our model and to subsidize 20 new registry partnerships. And then since then, we've seen steady growth and expansion, which I'll talk a bit more about. And I just want to note that this year, 2019, marks the 5-year anniversary of the launch of our program. So for those who are less familiar with NORD's Natural History Study Platform and Rare Disease Research Program, I'll just give sort of a high-level overview. So NORD provides the registry platform. It's a common infrastructure for longitudinal data collection. We have a core set of surveys to support cross-disease analysis. So there's a common core set of surveys that are the same across the different registries that we host on our platform. And then we also allow for the flexibility to support custom disease-specific surveys. So for those more nuanced questions that are truly related to each condition, we also have the capacity to support those surveys as well. So it's a tool to capture survey-based, patient-reported, and patient-experienced data in disease-specific registries across distinct rare disease communities. And then NORD provides the programmatic support around the registry. So we provide training, user guides, instruction guides, best practices, recommendations, guidelines. As I mentioned, we have a core question repository, a core survey set that we provide. We have templates for consent and marketing. Also for the IRB, we have protocol templates. And then we have an IRB partnership with an independent IRB. And then for our community, we really are focused on building a rare disease registry community. So we have a portal through our registry system for the registry leaders to communicate with each other and share resources. We bring our leaders together one time a year in person so that, again, it's a nice networking opportunity and a chance for resource sharing. And then throughout the year, we host webinars and educational videos, and we put out an end-of-year newsletter as well. And for those interested in learning more, I'm happy to answer questions at the end of this presentation or through follow-up, but we also do offer monthly demonstrations of our platform on the third Thursday of each month. So if anyone is interested in seeing how the platform actually functions, I'm happy to help you get you connected with the demonstration. And I should say, so NORD, as I mentioned, provides the common infrastructure, the core surveys, and then the data elements for those core surveys are pulled from the GRDR, the Global Rare Disease Registry Repository, the PROMIS standards, BRFSS. So they're validated measures for capturing, quality of life and other topic areas. This is just a high-level overview of some of the partners that we have on our registry platform. So we are up to 34 registry partnerships, and they're all in various stages of actively collecting data or development. And this is just an example set of questions. So for example, for the PKU registry, the different sort of question sets that are captured within the registry are represented on this slide. So about the participants, your sort of standard demographics data. We collect diagnosis information, so the date and type of diagnosis, treatment information, age at PKU diet, diet start and stop, medical food adherence to diet. We collect medical history, so vaccinations, physical function, activity, serious illness. We collect insurance information, so better understanding who's on insurance, what type of insurance, and then the medical costs associated with managing the condition. Education, so there's whether or not educational assistance or services were needed, and then family history. Mood, so the hospital anxiety and depression scale is captured in our registry, and then a maternal history, so pregnancy history and birth history and assessment. Oh, sorry, these were the question sets. And then for our community, so we have our 2019 stats. So we've, from 2014 when we launched through the end of 2018, we've grown to 34 registry partnerships. We have over 8,500 users, and we've collected over 45,000 survey submissions. And at this point, we have a nice mix of registries that are maturing, that have 2 to 5 years worth of data, in addition to newer partnerships. So there's a lot of cross-learning that happens in that sense as well for the more advanced registry clients that are kind of advising it through a peer mentor type network on the registry clients that are in the earlier phases of development. So these are just some of our early community successes that demonstrate the application and impact of the registry data. So in November of just this past year, 2018, a new mechanism was identified for SYNGAP1 that was informed by the registry data collected by the Bridge the Gap Foundation. There was a paper published in Nature, and it reflects the link between patient-reported registry data and lab-based research. So there were reports in the registry of children not feeling pain, for example, a child with a broken finger for multiple days who wasn't complaining about it, or a child that kept putting their hand in the dog's mouth with very little reaction or response. And so that patient-reported experience data really led to new pathways for exploration in mouse models, which then led to the identification of a new mechanism for SYNGAP1. And our Fibrous Dysplasia Foundation, they held a competitive application process for researcher projects to work with the FDF registry data. So they ended up receiving 6 proposals, and the institutions reflected, Boston Children's Hospital, University of California in San Francisco, and Harvard Medical School, among others. And then our registry community members are getting invited to different meetings and forums to present as experts on the registry data. So the Platelet Disorder Support Association was specifically asked by the FDA to present on their registry experience and the registry data at a public workshop on key ways to effectively engage with patient communities. So organizations are starting to seek out our registry partners as resources and experts in this space. So I'll just chat through a few of our new partnership models. So as I mentioned, we really started out with our model. Our original model for the registry was that NORD partnered with patient advocacy organizations. So it was a two-way partnership, and really, again, the intent was to help develop the capacity of the patient advocacy organizations to run and manage their registries, own their data, be good stewards of the data. And then NORD was the platform provider, but also an educational resource for the communities. And so just in this last year, we've actually expanded our model to a few additional types of partnerships. So one new model is that we now can include registries for communities that do not have a formalized 501c3 organization. So NORD can sort of sit as the registry sponsor or the program manager. And the idea over time will be to transition ownership of the registry back to the patient community once there is a formalized organization. But as an initial step, we decided to sort of put this out as a model toward reducing barriers to registry development and participation, and as a way for NORD to help elevate communities that don't yet have an organization to advocate on their behalf. Another model that we recently put out just in the second half of last year was the ability to run a sub-study. So where there's a primary registry on our platform, a third-party researcher or industry partner can partner with NORD and the patient advocacy organization to develop a sort of like a nested study. So it's particularly important, as we're all well aware, with small patient populations to keep the communities together, to reduce redundant and duplicative registry efforts and data silos. And this is really towards preserving the power of the data, but also for communication purposes and reducing confusion and research burden in the community, which ultimately leads to, reduces delays in scientific progress. So this sub-study feature, it allows a third-party researcher to come in, run a nested study on the IMRARE platform. The study can be time-bound or funding-bound. It doesn't have to be an enduring resource like the primary registry is. And so it sort of opens up the pathways for partnership. And I should also say the sub-study feature, it can have its own eligibility criteria and its own consent mechanism as well. So it's sort of a separate study, but that is related to the primary registry. And then our final model of partnership this year that we recently launched is that we're piloting a partnership with Trio Health as our analytics partner with the intent really to liberate the data from our registry. So we are working with our registry community to develop posters for presentation at conferences, manuscripts for peer-reviewed publications, and we're putting together a rare disease book which will speak to some of the patient stories as well as share some of the aggregated data from a subset of our registry clients. So really just kind of getting the data out there and the findings out there so that it's usable and actionable and liberating the data from the registries. So a few opportunities to engage. We are always open to exploring different registry partnerships. We have a collaboration with all of our registry partners, so if there's any interest in accessing the data on any of the registries that we host on our platform, we'd be happy to make that connection with the community organization and to help facilitate those conversations. And then as research project collaborators, so either on sort of original research projects or on disease-specific projects, we can also help to facilitate those connections as well. We're also always looking for high-quality speakers at NORD's events, so if you have any interest in that, I'm open to passing your information along. We will be recruiting for additional members of NORD's Scientific and Medical Advisory Committee in the next few months, so if anyone is interested in that, please do reach out to me. And then we're always looking for experts to review or write rare disease reports for our database. And NORD and the FDA have an MOU to facilitate patient listening sessions. So the FDA just in the last 2 weeks put out their Request to Connect portal. It's live. So this portal is an opportunity for patients and caregivers to submit a question or to request a meeting with the FDA. But it's also a way to for rare disease communities to request listening sessions that are co-hosted and co-facilitated by NORD and the FDA. And then as I mentioned early on in the presentation, we do have 2 events this year. So we have our new Living Rare, Living Stronger Patient and Family Conference in June in Houston, which will be followed by our Rare Impact Awards. And then we also have our annual Rare Summit, which is in October in Washington, D.C. So it would be wonderful to see folks there. And then if you have questions, I'm always available or happy to chat further about the specifics of our program or our research work in general, or just connect you with the right folks at NORD if the research department is not the right starting point. And thank you so much for your time today and allowing me to contribute to the conversation.
All right, thank you very much. I think we've had 3 great presentations, and now we are ready for Q&A and committee discussion. So once again, I'm asking the operator to open lines of committee members and organizational representatives. Committee members, again, will go first, and then organizational representatives will follow. As a reminder, please use the raise hand feature in Adobe Connect when wanting to make comments or asking questions. And when speaking, please state your name so that we have proper recording. So let's go ahead. I guess, Tina, while people are queuing up, in addition to the website that you have that provides advice to advocacy groups for setting up a registry, do you also have individuals who help support them if they run into difficulties or have questions as they get
Absolutely.
processed?
You can always contact the Office of Rare Disease, and we will hook you up with whoever needs to be contacted. So we're happy to help anytime.
Okay, perfect. Next we have Cindy Powell.
Hi, this is Cindy Powell. Thank you very much for your presentation. I think there's so much valuable information that we can get from patient-entered or caregiver-entered data. However, I worry sometimes that less economically advantaged patients and families will be able to, participate in things like that. So I'm just wondering if anyone has any thoughts about how that limitation might be overcome.
So this is James O'Leary. I think, that is a huge problem, and it's definitely a problem across, community-led registries, registries in academic institutions, and also in, incredibly well-funded industry trials. So this is kind of an across-the-board problem. One of the big things that I've seen that has been effective, especially with community-led registries, is partnerships with organizations that are able to be more on the ground. And that includes some technology fixes, like having iPads with registry surveys available in waiting rooms at clinics. But it's more of a kind of on the ground, people-based approach, which is making sure that you're partnering with care navigators or community liaisons or promotorists, models, and that is expensive. And so a lot of people do cut corners on that, and we need better solutions in that space.
Yeah, I agree with that. That's one area we need to really reach out and do work in.
Yeah, this is Vanessa from NORD. So again, I do echo James's comments, and it is certainly something that we need to be very intentional about so that we are ensuring that our samples are representative, because, of course, diversity in research and representative sampling defines good science, but also better medicine for everyone. In our model, as I mentioned, the registries really sit with the patient advocacy organization, so there is a lot of sort of one-to-one outreach with the communities, and what we are finding is that we're actually undergoing an assessment across our registries now because some of the patient populations are quite skewed in terms of racial distribution, also socioeconomic status. So we're doing sort of an assessment now to see who on our platform has actually done well at recruiting a representative sample and what we can learn kind of as best practices from across our community. But what we are finding is that folks who are really on the ground, like who host community events or host like a conference or, exactly what James said, can sort of bring the registry to the community. That seems to be working well, which is, of course, a big lift in terms of resources, human and time resources, and also financial.
Thank you. Sue Berry next.
Hi, can you hear me?
Yes, we can. We can.
Thanks. I just have to make sure I turned my mute off. This is a very exciting group of presentations and really speaks to some of the long-term needs we have. But a couple things I just wanted to bring up and ask a little bit more about. One of them is the focus totally understandable on patient-centered and patient-entered outcomes, but there is an equally important and necessary contribution that has to come from clinicians and other knowledgeable people. And that has been a very difficult task to accomplishment. All of these registries are really compromised in the long term by degrees of sustainability and by the feasibility of data entry. And I'm wondering if people could comment a little bit more on things like AI and other strategies for data mining in electronic records, for example, which has been sort of a kind of a pipe dream, but we really haven't gotten very far with. And then sort of the mismatch of resources, it seems like, that have been appropriated for other conditions as opposed to rare diseases. Someone, I think it was Tina, that highlighted the commonality, how often rare diseases are seen as health impacts, but we spend $1 bazillion on cancer and not very much on this collective group. I'm just thinking of a fantastic presentation I saw by one of our oncologists for a whole clinical trials network that they have set up for first time in people trials for children with cancer, and I'm so happy they have that, but we've got nothing like that. So I guess what I'd say is feasibility, sustainability, engagement of clinicians, and resources. Those are the questions that I see as needing to be able to address as we talk about all of this. So I'll leave that for the comments from the committee, from the panel. Thank you, and thank you for the presentations. It was very good to hear all of this at once.
Sure, this is Tina. One of the things that we are trying to focus on in the Office of Rare Disease Research is that make people aware that rare diseases as a whole are not so rare, and really emphasize that. And that's a message we're really trying to get out. And I think the more we get that message out, the more people might start thinking about us as a whole, like cancers, as opposed to individual groups. And I think sometimes that it might be important that the individual rare disease groups think about working together. Instead of having 7,000 registries, working together and partnering to build a platform to have their own the individual registries there together, their own individual instance, but the base they can all pitch in together and work on. I think that might be a way to go, and I think that's a little bit what we're doing with some of the clinical research in the RDCRN, in that, let's work together, let's build a common platform that can be shared, and let's leverage that. And I think until we start doing that, we're never going to be able to fund anything because we're going one by one by one. And I think that's a very challenging and way to approach research.
This is James. On the clinical data front, yeah, things are challenging. If you look at things like PCORI and PCORNet as examples, where there is kind of investment in learning healthcare system models, really, on the healthcare system level, how to implement, platforms on top of their electronic medical records and internal processes for making that data available. Things are progressing, albeit slowly. But on the artificial intelligence front and data mining, it's just incredibly challenging, because even though we're consolidating, the EMR vendors, for example, the majority of health systems might be on Epic, but they're on 300 different versions of Epic. And so it's incredibly hard to build anything that can do this consistently across structured and non-structured data. I think that we're getting there, but more often what you see from examples, like I mentioned earlier, is that you just need to build a whole another system on top of what is already there to make it happen. Disease groups that have partnered with health systems to do this in collaboration, I think are also very interesting examples. So like Parent Project Muscular Dystrophy is a great example. They really wanted to do their patient-reported data. They have a very robust system, but they also wanted to collect clinical data. A lot of those groups, though, wind up essentially funding clinical sites and then putting requirements on for entering of structured data, and then coordinating those two data sources together, which is not, everybody can't do that, obviously. It's very expensive.
And this is Vanessa. I won't pretend to be a technology or AI expert, but I do just want to sort of put a thought out there that if we are mining skewed samples or unrepresentative samples, I wonder if we need to be cautious about who the models for AI will be developed around or off of.
Other comments from the panel?
Sue Berry.
All right, we have Sue Berry then.
Sorry, I'm saying so much, but I wanted to comment on behalf of SIMD and check to Sean can't be on today because he's on another webinar responsibility. So I wanted to throw in a pitch for that organization, which is that Sean is spearheading an effort on the part of the SIMD to try and bring together the clinicians that represent the metabolic disease care community to try and think about how we can do a more comprehensive sharing of information and gathering of data across metabolic conditions using the SIMD as a point of origin, and with the idea that the clinicians may be able to help facilitate some of this conversation. The same challenges will still apply for SIMD as it has for other groups, but just a commitment on the part of the metabolic disease physician and research community that we want to make that happen and are going to try and contribute to the process by having a organizational effort on that part.
So Sue, this is Tina. Some of the NIH institutes and FDA also have natural history initiatives that are out on the street over the past few years. I think NICHD did as well, to really help groups come together and start collecting natural history data.
This is Sue. Tina, that's fantastic, and I think we all kind of keep our ear to the ground about those options, but I think we all do suffer to some degree from the one-off, if you do it with one group, then you do it with another group, and finding some more concerted ways to bring the rare disease community together more generally so that we can leverage some of that people power it's gonna be really necessary. Without losing the need for each individual condition to be able to define its own history and so on. So if we are going to develop a children's oncology group for rare diseases, we could go a long way. So
that would be cool.
All right, now I have Cindy Powell.
This is Cindy Powell again. One of the challenges is, because of the rarity of most of these diseases, if you have a very enthusiastic family, they're likely to sign up, into more than one registry if there is one, or participate in various tests. And I think, Vanessa, you may have mentioned this on one of your slides, but any thoughts about how to, preserve patient confidentiality and yet make sure there's not duplicate cases of, patients who are in more than one registry?
Yeah, this is Vanessa. That's a great question. And in terms of interoperability, it's a challenge. I mean, the GUID is one tool that's out there. On our platform, we can track. Each participant is given a unique participant ID, so we can track across our registries, but it's a fairly limited pool. So it's certainly something that we think about because we would like, of course, our data to be more easily interoperable with other systems or shareable with other systems, per the terms of consent as folks are contributing their data. But I don't know if that answers your question, but it's certainly something that we're thinking about internally, and we've really only addressed it within our community.
Yeah, thank you. This is Cindy again. So, I certainly would advocate for the need for a GUID for many different reasons, for just basic needs in newborn screening where, children are often given the same name when they're born on the same day in the same hospital, and it's really a challenge, and it may just be part of our healthcare system with the difficulty in this and a lot of pushback over the years in, people worrying about loss of confidentiality and the government having information, but I do think that's an area that needs to be explored further. Thank you.
All right, we have an internet comment from Joe Schneider that Catherine will read.
Okay. Thank you. This is Catherine Riley, and I'm reading in a comment from Joe Schneider, who's a member of the Follow-Up and Treatment Work Group, in response to the discussion on registries. He said in his experience as a chief medical officer in a large healthcare system, there was no way they could financially support electronic connections to all of the multiple registries in addition to many of the other registries that other large organizations require. So it's true for both the hospitals and physician practices that he's worked in. Clinicians who dealt with these registries were frustrated that they had to do everything manually. So the many-to-many connection model that we currently use for registries is inefficient. If there's a desire to populate these rare diseases and newborn screening registries with clinical data from hospitals, physician offices, and other clinical organizations, then there needs to be a single place to which these organizations can report. The single place then can send the information to individual registries. The American Academy of Pediatrics is in the initial phases of considering this, quote, report once, distribute to many, end quote, model. I strongly encourage discussions to find a way to get closer to this approach, regardless of who's the single receiving group. Thank you.
All right. So we have nobody else requesting to speak. Oh, we do?
Melissa Parisi.
Oh, Melissa Parisi. We're going to give you the last question, comment.
Hi, this is Melissa Parisi. It's an awfully big burden to be the last speaker, but I wanted to make a couple comments. There was a muscular dystrophy coordinating committee meeting, also a FACA committee that met on Wednesday, and I know there's some overlap with some of you who are on this call, but I mean a lot of the same themes were emerging because there was a special emphasis in discussing registries. And of course I want to thank our three presenters for what they had to say. I would like to echo some of the comments that have been made and the importance of really trying to have some sort of global unique identifier that can link data sources from disparate data on the same individual from disparate sources, because the redundancy that can sometimes exist for enthusiastic families who may want to participate in more than one registry can be very challenging. Sue, I also like your idea of trying to have a more concerted effort for natural history studies. At NICHD, we do have a program announcement with specified review that is for specifically newborn screening conditions and natural history studies. But, those individual studies are, when they do get funded, we don't necessarily have a good way to coordinate all the data in a useful manner, aside from some of the other resources that have been created, such as the Newborn Screening Translational Research Network. And then finally, with regard to Dr. Schneider's last comment, I think that's the holy grail, really, is being able to combine data resources, not only patient-reported data, but clinician data through the EHRs and additional data that may be collected through advocacy groups and other mechanisms. And I was really intrigued at the Muscular Dystrophy Coordinating Committee meeting on Wednesday by the presentation by Parent Project MD, trying to really develop a model, a template for combining these data sources in a HIPAA-compliant and most useful way. So, it's early days, and it's something we've been talking about, it seems like, for at least 5 years, but I'm optimistic and hopeful that we will have tackled some of these issues that are largely kind of IT-related and administrative and just a coordination effort, which is really overwhelming, but it's really essential for the field to move forward.
All right, thank you for those comments. I think that this has really begun an important discussion for us, and I certainly want to keep in touch with our 3 presenters today and their organizations. I think this has been really excellent panel and excellent comments, and so I think we can move this along, and really look forward to April when we begin to look at some individual registries and perhaps help bring these all together in some form of recommendations or ways that we as our committee, with the work that we do, could potentially utilize the information that might be available through these registries, as well as maybe states can for long-term follow-up. So again, I want to thank our panelists. I think this has been a great discussion. Thank you.
Thank you.
So the next item is new topics. This is open to committee members and org reps. Are there any new topics that have come to mind that you wish the committee to be considering at the present time?
Dr. Ostrander? Bob Ostrander.
Bob Ostrander?
Yeah, hi. I don't know if this is in our purview or not, but I kind of think that it is, and that is whether we should be talking about or thinking about the direct-to-consumer newborn screening that's being done outside of the RUSP process and the state panels. The whole direct-to-consumer issue has obviously become a big concern for everybody, and at least one of the companies, SEM4 or whatnot, that does Natalis, will do a newborn screening panel with the doctor's order provided by someone that they contract with or have without actually even conferring with the parents at all. You send in you send for the kit, they send you a questionnaire, you swab your baby, and then a doctor reviews the questionnaire and enters the order to comply with the FDA. And again, I'm not sure, how that all fits, but I think it's got the potential to cause harm and muddy the waters and, open a Pandora's box. And it is a heritable diseases issue of newborn and children, and it may be something that we should, talk about its implications and, potential policy pieces. I've been working with this both on the adult and newborn and children's side with the AAFP about developing a policy statement about what the sort of minimum requirements should be for these sort of tests to be done in terms of just run-of-the-mill standard basic ethics, informed consent, interactive pre-test counseling, interactive post-test counseling, and so on. But it's happening out there kind of around us, and I guess I kind of think that we should it should be on our radar, and we should have thought about it and talked about it.
All right, thank you, Bob. That is something that we should really begin to think about and see whether there would be a potential role for us. May Baker.
Yeah, hi, this is May. The one thing popped to my mind is carrier screening. When I said that it's not just saying, well, in newborn screening, sometimes we unintentionally to identify some carrier. My talking is actually intentionally to do in adults. Like if we talk about newborn screening as a system, can we have a more connection with OBGY group? You know, do we have better understanding? If it's justified to newborn screening, is that justified to encourage to the carrier screening for this group of disorders? Because, you know, when we talk about whole exomal, whole genome, and at this today, the timing still, turnaround time still is big headache, and beside other issues. And our thinking is, if we have newborn screening, we have a follow-up, we have a clinician involved. On the downstream, we are doing work. At that time, we start thinking of upstream and link. So if we talk of precision medicine, talk of personalized medicine, seems kind of into this, because then we'll be more targeted, and I think the partially will help the protective value of this kind of, because you have this genetic information, and I think something I would be interested in see this happen.
Thank you, May. We'll keep that on the books as well. Thank you.
Hi,
all right, I see.
This is Debbie Friedenberg, and I just wanted to echo the previous concern about DTC or direct-to-consumer testing around newborn screening, because it is becoming a larger concern in which some of it's being marketed as supplemental screening, but some of it's being marketed as replacing state-based newborn screening. And so I think it is something that should be on our radar as well.
Thank you. Okay.
I don't see any other.
I see no other hands up. So I think I want to thank everybody for their participation in this meeting. As you know, this is a truncated meeting which had to be rescheduled because of the issues surrounding the government shutdown. But I do think that it puts us closer to the next meeting, which is going to make everybody at HRSA work harder. But I think that in spite of that, this has really been a good meeting, well organized, and I think we got a lot of information, and it's clear that we're making progress with a number of the projects that we have begun, and so I really look forward to the next few meetings to see how these all work out. Remember, the next meeting is going to be April 23rd and April 24th. This is an in-person meeting at HRSA headquarters, and it will be available by webcast as well. So again, thanks to HRSA, thanks for everybody who worked to organize this, and thank all of the speakers and participants. We'll look forward to seeing you again at the next meeting. So thank you. We appreciate your time and your efforts for newborn screening. That'll conclude the meeting. Thank you.
Thank you. Bye-bye.
Thank you.
Thank you. This does conclude today's conference. You may disconnect at this time.